Recording in progress.
Muy buenos días. Con el gusto de saludarles.
Good morning. I'm so glad to greet you. Today we are in the International Congress of Social Security, welcoming you to the second day of the third International Congress Mental Health. As presenters, we are going to be Dr. Joaquín Castillejo and myself, Maria del Pilar Castillejo. Can we start? Okay, hello, good morning. I am Joaquín Castillo, psychiatrist, doctor, coordinator of the mental health and addictions of the IMSSS. And to me, it is an honor to be here with all of you in this second day of activities. Now we are going to start the topic today. It's what was made and what is missing regarding mental health. And we are going to start with the first topic of the day, which is the conference of strategy of the health service to adolescent centers. The speaker will be Dr. Tania Eugenia Tobar Trejo, and I am very glad to provide you with her story. She is a doctor with a specialty on family medicine.
Con brindar atención médica de
She
medicina.
has been providing services on family as family medica in Tamaulipas. She is a supervisor for the regional Bienestar IMSS service in UAPS, Tamaulipas. She was also the coordinator in the IMSS Bienestar program, implementing the perspective of gender in the strategy to detect and for the innovation of women older than 15 years old with gender violence, also with the ordinary regime, and supervisor as a doctor in the reproductive medicine and coordinator of Mass Bienestar with the federalization of medical units. Currently, she's in charge of childhood, adolescence, mental health, and gender equality of the IMSS program. And we welcome her to this conference. Good morning to everybody. To me, it is a pleasure to be with you today in this third International Congress on Mental Health. Thanks to the coordinator of this ordinary program for the invitation. Please receive my greetings, as well as from Dr. Manuel Cervantes Ocampo, who is the coordinator of the Integral Medicine, and Dr. Salazar. The program IMSS Bienestar for those who do not live in the Mexican Republic, it is a program with more than 43 years old in our country. It is a federal program serving the population with no medical services located in marginal areas in our country. Next slide, please. The adolescent population that we have under our services is 2,600,043 people, 1,019 women, and 1,675 men. Next one, please. The program IMSS Bienestar is concerned since 1997, and it started with the integral attention model services. These centers were created as a response to the needs of the adolescents regarding sex, and reproductive medical services in order to decrease mother mortality. Initially, this model in these rural adolescent centers were based in the integral attention of the rural adolescents called MySAR. Since then, since 1998, they evolved in order to answer the epidemiological profile that is so changing in our rural and marginal areas in this country. And it was implemented using new purposes and goals. The main objective is that the adolescents be in charge of their self-care, getting skills for their own life, and to take care of their own sexuality using these hospitals and centers included in the program under the human rights respect and gender non-discrimination. Next one, please. These rural centers for adolescents then were changed to another name. Right now, they are called health centers to take care of adolescents in order to cover the units in charge of the government. In these centers, we also integrated currently we have young leaders in our units, and the education strategy provided in these medical centers and hospitals was formed in 1984 with 4 modules: education. The first one is associated to the prevention of pregnancy, non-planned pregnancy and infection of sexual transmitted diseases. The second, prevention of overweight and obesity. The third, prevention of violence. And the fourth, prevention of addictions. They are located with 80 centers. These are areas that are located, physical areas where the strategy will be done using workshops, and each one has workshops where 80% are techniques with participation, allowing the adolescents to express their opinions, to express their comments, and be able to make an analysis of the content. These centers have a cross-section axis for medical care, for dermatology, and preventive medicine. However, after the COVID-19 pandemic, that was something that changed the world, and when we saw how anxiety were affecting them as well as stress, and how the access decreased to the units by the adolescents, and how the violence increased. Considering suicides, then we started with another model for mental health in order to work with them, self-esteem, self-care, skills for life, and also to start working with suicide and anxiety and depression. However, all this part of mental health, with all the purposes expressed by the President of the Republic, it was necessary that the program started with a program focused in an integrated way in order to encourage well-being and health of the population. So in the 2022, we implemented this integral service with the 80 hospitals included in the program. This service of integral care is also based on a model of integral service to health, and we are working along the life in the preborn phase to 6 and then to 9 years old, and then 20 and over age. Here we can see the structure of the areas in this program where we manage all the mental health programs. So we have a center with an integral development area where we take care of 0 to 6 years old and where we make an assessment of their development by using the ERI test. Also, in this same program, we manage the psychological assessment of model for boys and girls with a risk of a delay in their development. We also use a test, and we use also this scale of behavior for parents corner, as well as the autism scale for children cars. We also have the CAI area where we take care of children. Initially, we are taking care of 6 to 9 years old, starting on 2024. We will start 6 to 9 year old. And here we also implement a strategy for their education as well as for the education of their parents in the hospitals and also in the schools. Through these centers to take care of the childhood, we can detect anxiety and depression in kids, the behavior distresses, deficit of hyperactivity and attention. And we also have a strategy for childhood abuse. At the CASA centers of education, also with this education in the schools and hospitals, with first level units, we identify the anxiety and depression disorders, feed disorders, substance consumption, suicide, self-injuries, epilepsy, behavior disorders. And after 20 years old, we are identifying all the problems based on the drug abuse. We also have a strategy for gender violence. The implementation of this integral service for mental health works together with other institutions in order to try to make it more appropriate and with the guidelines according to the rural area where we are working. So we work with the Secretariat of the Mental Health Institutions, with the psychiatric care services, with the mental health coordination of the IMSs. We have the coordination of the IMS for the training of our staff, and also with the Mental Health and Addictions National Commission. For that purpose, in order to implement this service for the mental health service, we implemented physical spaces inside the hospitals for the patients once they are referred by the general or family doctor to the psychology area. Let me tell you that in the program, we currently have 93 psychologists in our hospitals who are in charge of taking care of the mental health service. We enable these spaces and we started to work on the training of the psychology staff at the SEDATU, urgencies on mental health, and the service for suicide patients. After that, the psychologists were trained and the medical, the nurses and social workers started to be trained. Besides that, the psychologists received some training regarding assessment for psychology purposes on pregnant women. What we are using for this service is to take care the priority disorders and also taking care of the behavior. We are working on suicide with a model, taking care of the risk and also any disorder associated to drug abuse using early detection. Besides that, in the visits to the doctor, we also take care of the priority risk considering our model. The patients are taken care by the family doctors, and from there they are transferred, if necessary, after a good assessment, that they are transferred to the mental health doctor service. We are really concerned regarding prevention because we are trying to strengthen their capacity to regulate emotions, to give alternatives to the risk behaviors, to promote the resilience development, and to favor social networks. Last year, we started with this clinical attention to adolescents and to the rest of the population. We made an exercise to strengthen our psychology staff. There we had a collaboration of CONASABE, where they assess our clinical service for all our psychology staff. And we strengthen their clinical service, and that allowed us, using their help, to refer the patients to another level of service if required. Regarding attention, we are trying to prioritize the right to be respected of the boys and girls and adolescents. And of course, we are still have an ongoing work together with the other institutions participating in the prevention of pregnancy for adolescents in ATEA and all the other areas that are still in force. We have huge challenges in these areas where we are working because we have different contexts that make us to face the reality. The biggest challenges are forced matrimonies in these regions, abandonment of school, addiction to internet, self-injuries, sexual behavior at early ages with no protection and with different partners, difficulties because of the communication means interventions, social exclusion, and violence. What is next? We really needed to ensure that they have access to mental health services, receiving on-time treatment. It is important that we can make it that adolescents do not have a hidden agenda, because sometimes they go to see the doctor, but they do not express everything that is happening. We have to promote all this at the community level so that we can prevent the risk and exposure there too. We have a community organization that is the center thereof, and through them we must do our work in order to reach our goals regarding mental health on adolescents, in order to work on topics as the increases in violence. We must follow these prevention programs where we are actively participating, and we must continue working on the national strategy to prevent pregnancy. This is something that we cannot do by ourselves. We must recognize that mental health and prevention of addictions and pregnancies in adolescents, it's part of an agenda. Mental health and welfare of adolescents require the cooperation of all the institutions and all the society. We must have an environment that is appropriate in order to reduce this health risk affecting all the adolescents and children. And as UNICEF mentioned, taking care of the adolescents, because it is essential to fight the poverty, inequality, and discrimination in any of its forms. Thank you very much.
Muchas gracias. Gracias.
Thank you very much. Thank you, doctor, for this topic. Here we can realize how important mental health is for the adolescents and children. Thank you very much for all the actions made in favor of the population, because through an on-time service, we can prevent many of them. Do you have any question?
Bien, aquí tenemos una pregunta. Le preguntamos, doctora, ¿dónde podemos...
A question, doctor. Where can be trained? And I am talking about the psychologists that do not belong to IMS in order to be covered on suicide and mental health. We have platforms that are available for all those interested. Some of them are in the National Commission of Mental Health and Addictions, some other platforms priorly called INSABI. Here we have some platforms. First of all, you have to check the 2.2 version in order to have access as a non-specialist, because they were made especially for all psychologists, the social workers, family doctors who are willing to share this responsibility in order to start taking care of this drug abuse problem, and to refer the patients whenever necessary. Okay, before continuing with the next panel member, We remind you that we have simultaneous interpretation, English and Portuguese. You can click the icon with the earth located in the lower part of your screen, where you can select your preferred language. If this is clear, well, we would like to thank also the participation of Dr. Tania Eugenio Tobar Trejo in this conference, and to thank all of you for being here with us.
Gracias, doctora Tania.
Thank you very much, Dr. Tania.
Vamos a continuar. Queremos.
Okay, let's continue. We would like to thank beforehand to all of our audience and our panelists for your participation in this second day of the third Mental Health Congress. And now we'll move on with our next panel, please. Of course, we would like to introduce the next panel. It's called Sectorial Plan for Mental Health and Addictions from the Theory to the Practice. As a moderator, we have Dr. Luis Alberto Salinas Torres, who is a surgeon by UNAM. He has a specialty in psychiatry by the Hospital Fray Bernardino Alvarez. He has a postgraduate degree by the psychotherapy organization. He also has a postgraduate degree for psychotherapy to children and teenagers by the psychotherapy institution in Mexico. We know that he had worked in the community center for mental health called COSESAM in Cuauhtémoc. He was a teacher in the psychiatry and mental health department in the medical school of UNAM. He's a specialist in childhood and teenager psychiatry from the Hospital Juan L. Navarro. He is currently holding the head position in the health and mental health for children in the Mental Health Institute in Mexico. Thank you very much for the invitation. I hope you can hear me okay. If it's this way, just thumbs up. Thank you very much, Dr. Lore. Well, today, I believe I get to present on the sector-based mental health plan. We have an amazing panelist that is not only have participated in this roundtable, but they have made great efforts in trying to bring together different projects across the different places that they have been working in. Something that unfortunately we have been dealing with when it comes in timely manner, we didn't really have a proper strategy to provide mental health and addiction care for the population. And as it is known, the mental health system sometimes, or the way it has been, it's been severely divided. So we haven't been able, until now, we haven't been able to hold a strategy that would cover the different needs across the country. And then again, luckily, these four people that I have the pleasure to introduce have been addressing this target and this mission, essentially being able to create a cross-sectional strategy to provide a proper response in the country and address all of the units in mental health and addictions. We saw these complication related to the deficit, to the DEAN-based activities. You might have heard this from the WHO. And nowadays, luckily, from the Ministry of Health, Mexican Institute for Social Security, ISSSTE, and other institutions like the Ministry of Defense, Pemex, and the Navy have gotten together have made these elements available, and we can address it in a better way. This matter of stewardship. I'd like to introduce Dr. Lorena Lopez Perez. She is a surgeon with a specialty in psychiatry from the medicine department in UNAM. He has a specialty, a master's degree in therapy, in conductual therapy. He has postgraduate studies in UNAM as well. She is also holding postgraduate studies in hospital administration from the National Political Institute, and she also holds the Directorate of Psychiatry Services in Conasama, Mexico. Without further ado, I would like to give her the floor so she can start her presentation. Okay, I will be sharing my screen. Just let me know if you can see it. I believe so. Okay, great. So, thank you very much. Thank you very much, Dr. Salinas. It is a true pleasure and honor to share this panel with such amazing colleagues, with Dr. Norma. Since day one, we have been working alongside, hand in hand. I mean, the first day I got to the strategy, because she was here before, we have been collaborating, and there has always been amazing collaboration and a great commitment, because the actions that are being created, they can, so that the actions that are being carried out can reach the people that need it. It is also an honor to be here with Dr. Ledesma, that she has been pushing forward everything in public health. She has been very persistent, and she has been a great piece of us being able to talk about this sectorial plan. I appreciate all of you. Greetings, and I'll start. So, as many of you might already know, and all of the participants in the National Commission for Mental Health and Addictions in our country since 1984, we didn't really have a modification in terms of the regulations or guidelines that were connecting the stewardship in mental health and addictions. It is to say, probably around 4 years, we have been participating in a dynamic that had this model that wasn't really working for society, that didn't really provide proper mental health care, and it wasn't even responding to the interest of care, and it wouldn't even follow the logic of paradigm and the changes of insights that were happening in the world. In 2011, we heard this from the WHO, and then PAHO mentioned it, and so on and so forth. So this brings us to 2019, where we saw this proposal of a modification on the mental health and addiction chapter of the General Health Law, which then again wasn't modified since 1984. However, after this modification, we have many other strategies working in parallel, like the need of having a specific program when it comes to mental health and addictions. We didn't really have that before, where we would be able to link addictions to mental health, where we could see addictions as a mental health issue, where the health component that is normally quite resistant to change, but there is also a lot of stigma around it, could perceive mental health as part of the medical care, and all of the public policies in the country and the public policies that were generated, in other terms, were also involving mental health. Since mental health is a cross institutional and a cross elemental issue with many pathologies, not only the ones that come from the loss of mental health. So, in this regard, one of the strategies that were created was the Mexican model for mental health and addictions that was enforced in 2019, where the first proposal was then again to have a commission addressing these issues, where we would bring in all three steward elements that are the utmost important ones in mental health: the National Commission Against Addictions, the Psychiatric Services, and the Technical Secretariat for the Mental Health Council. So this becomes relevant since the idea was to recover the stewardship in mental health and addiction, to fuse together these two components and even work together with taxable resources to make more practical and better divided and better distributed the resources available. So the point is that this commission will have the powers to determine, supervise, and assess every healthcare provision when it comes to mental health under any model and cross-sectional based on the levels of care. Another important change that came with this model, another insight, is that this is a model that's entirely based on the primary healthcare, because mental health has to be regarded as a component of the primary healthcare. Of course, understanding that the primary healthcare would be the first level of care. Because if we provide this focus, we are going to be able to improve the technical competency of all of those service providers. It is to say that it's not only the intent of the people that are experts or have a specialization in mental health and addictions being the only ones that have the required skills to provide care to these users. For instance, I like to have as a clear example where we say, okay, it could be a trauma doctor in your care, and you will be addressing high specialized if you maybe are specialized in the spine, but to your users, even in the private sector or the public sector, you will be able to have the skills to address as first level of care all of those users that require any sort of care when it comes to addiction of mental care and mental care. And this is what this model is aiming for. We're also looking at increasing the coverage of services, and this is why we have this sector-based plan that I'm going to very briefly discuss to fight stigma and discrimination, because in high-income countries like Canada, where they have the services and they're available, people are still not looking for these care. And the issue is that despite them being available, from the health component and the social component, there is still a lot of stigma and discrimination when a user has any sort of issue regarding their mental health or addiction. Another important thing on this model is to push forward the community model. So we want the community to become a active element to address everything that's happening in them, and also the cross-sectoriality. So what we have learned is that what we're aiming for is for mental health to link across all of the public dependencies on three levels of government, so we can create a synergy and we can restructure the social net. And this is relevant because the mental health determinants have a very high impact in the loss and diagnosis. And we have another important section here that's cross-sectoriality. So we understand that within the sector, there were some amazing isolated efforts where the proper capability of the institutions wasn't enough to address all of the care. So the IMSS had really good things that were being implemented, and maybe we didn't really have the capability as Ministry of Health, like with SEMA, to reach some places. The ISTE had their emergency mental health system, so we started networking this, we started connecting this, and that's how we created our intersectorial plan for mental health and addictions. This is all based on the reform to the General Health Law last May 16, 2022. So I want to mention that the main target of this sectorial plan, everything, all of the specific objectives go along the Mexican model. They match the specific action programs, but they also match the sector-based plan when it comes to health, which is the project of this presidential term. So we are looking at an improvement in the stewardship so we can have a direction and a vision on the mental health matter to the Ministry of Health. So from the Ministry of Health, we want to have a unified stewardship and a unified direction so we can provide comprehensive care in this matter. We're looking at healthcare to be comprehensive and so that we get to be service provider and exchange services when our capability isn't enough to address the required care. Another point would be that we have this perspective of human rights and protection to mental health with an emphasis in childhood and teenage years. And there is a really important highlight when it comes to psychosocial disability. This is something that our country might be looking at the restructuring when it comes in a change of mindset to understand what are the different types of disability. This is something that's ongoing. Another important thing is that this specific target allows us to favor the legal status of the people. Understand that all of these people require their rights to be addressed and they can understand and make decisions over their own treatment. And it also allows us, as it is cross-sectorial, it allows us to help to eliminate the stigma that has historically been impacting the users. Another relevant thing is that once we're working as a sector and we're optimizing the resources that we have when it comes to budget, but also the resources that other institutions might have, this allows us for the service portfolio in this matter to be broader, and it would also allow us to compensate, increasingly compensate the needs for care. Another thing that we're also doing from CONASAMA when it comes to the cross-sectorial care is that we are updating the official Mexican standards towards community integrated or comprehensive community models. So the NOM 28 and 65, they're based on mental health, and we're looking at merging them so that they have a full-on community component. So as we know, to this end, the Ministry of Health created the National Mental Health Commission and Addictions last May 25 of this year. So the specific objective number 2 of this sectorial plan is that we design and implemented an educational plan for human resources oriented that it's non-specialized and specialized in mental health and addictions so that we can increase the coverage and skills for care. To do so, since this administration, we carried out a strategy to reduce the gaps in the mental health and addiction care, and we have over 100,000 people trained in this matter. We have also provided training courses for the community, mental health for the community, which is for non-specialists in mental health and addictions, and people that coming from different sectors that should hold the proper tools. For the first time, we created a national strategy for suicide prevention, which is a unique strategy in the Americas because it is public, where 12,893 healthcare professionals have received training in the management of suicidal behaviors. From here, we also develop a master training plan, an educational master plan that brings in information from across the different specialties at different areas and sectors. Now, when it comes to the specific target number 3, so we can get this stewardship back, we're looking at increasing the quality of mental health and addiction services so that we can improve diagnosis and work skills to the community. So the plan is that we're all working together to add up what every government level has to add up to the mental health requirements. And specific objective number 4, we're looking at improving the quality of information and research in mental health and addiction so we can have the proper elements for the strategic and operational decision making. Why is this important? In our country, we have a need or there was a need to carry out a restructuring of the IT system so we can have the data available for us decision makers to carry out evidence-based decisions and to create pragmatic and useful decisions to the community. When we have common indicators, this allows us to have more information, collect more data, and have a better resolution-based ability. After 2023, we modified the daily forms, everything that has to be recorded when it comes to mental health and addiction, focusing and highlighting the activities carried out by all of the operational profiles, not only the medical component. And another important thing is that since this year, 2023, since January this year, all of the 12 keys that are connected to suicide behavior became part of the epidemiology surveillance. This would allow us to create better networks and make better decisions when it comes to suicide prevention. We know that in our country, we have been having a relevant increase from 16 to 29 years, but 16 to 19 years, we are also seeing this increase as it goes. So the reality is that this is a starting job. This is a very important effort from all the people involved in the sector so that we can allow and we can achieve closing the gap of the mental health in our country. We have a range of the 13 to 17 years in this gap when we start seeing these suicide behaviors, and we're looking at a reduction because this is a must. We understand that after COVID, we could see this increase in the needs of the population for care. In our country, the more we hear about mental health and addiction, people are losing this fear of addressing their needs. So there cannot be promotion and prevention strategies if the sector isn't all interconnected, because we're all aiming at the same point, helping the population. They might be IMSS, they can be ISTE, and the other, and some other time it could be the Ministry of Health. I'd really like to thank you. I thought I was running out of time, that's why I was rushing. So let's discuss at the end of it and we can share insights. Thank you. Thank you very much. We would love to have a lot more time available because we might be able to address everything else and all the details in the objectives that you mentioned. There should be a better awareness of these cross-sectorial plans so that leaders, strategic and technical leaders get to know it, and so that they are aware that within institutions we're working towards an improvement of each and every one of the objectives that you have mentioned, Dr. Lorena. Now, I am going to be presenting our next psychiatrist, Dr. Edgar Flores Marquez. He is a Navy surgeon from the Navy school. He's a psychiatrist from UMAE, Specialty Hospital, Centro Médico Nacional Siglo XXI from the IMSS. He has a postgraduate study in legal psychiatry certified by the Board of Psychiatry in Mexico, and he is Army, he is a Navy psychiatry doctor, MD, and the current position as he's holding, he's a Deputy Director of Mental Health in the Ministry of the Navy. Go ahead. Hello, good morning, everyone. Thank you very much for the invitation to participate. I believe this is a highly relevant element to address.
Es un interés universal por los efectos mismos que hemos estado viviendo últimamente. Y bueno, no es ajeno tampoco
And we know that this is not strange regarding the army, mostly in Mexico. because this type of experiences and forums allow us to take more the sensibilization to certain commands to the benefit of the mental health of the population. Therefore, since the Marine Ministry, under the logo of with you taking care of your health in the general direction of the Navy Health, we have a mission in order to update the policies that we have regarding what we have been talking about and what Mexico has done, because it is very important in order to add all our interinstitutional efforts. These policies will help us to reform the resources and to address them through the promotion of health. So with this vision, the Ministry of the Marine has implemented new strategies. And regarding mental health, we are not being left behind. It has been working really well to recognize all the staff in charge of mental health in the Army and undoubtedly in the Marine. Fortunately, we already have a deployment of psychologists and psychiatrists along all the country in 39 hospitals in all the ports where we have a Navy area or region. And here we have a huge advantage because we have this deployment. Because it's not only units or establishment for Navy Health, but we also have some staff in management positions and operating positions that can take care of the sensibilization part. We know that they have a very good capability on training and sometimes with advisory services or for decision making, but mostly for prevention and promotion programs through conferences and by approaching the staff and their families in order to be in places like these conferences to promote health, because this is a day-to-day duty. Then, therefore, through the attention provided in the different units of the Ministry of the Marine, we have 195 psychologists and 10 psychiatrists distributed in the different health establishments. And as each sector in each place have a different culture and the different authorities, each one has a different challenge, but undoubtedly in the military environment, we have places where we can go to exercise as our efforts. And here we would like to rescue the stigma topic, because it is a topic that is happening with us, and it is reinforced when we have a difficulty to express our emotions due to the image that a military has before the population. So it is not easy to go to mental health services. It is not easy for the military nor for the families. So we are striving to decrease the stigma, because it is a double stigma in our case. Sometimes it is like a discrimination, and likewise we have a difficulty to take care of themselves, and that results that they do not try to find the non-working days because they have a responsibility as allocated to all of them. and that may result in different complaints. And at the end of the day, it can be a legal or medical problem. Undoubtedly, the military staff have some guidelines and rules that sometimes allows to help to this growing stigma. And this is a topic that we are trying to cope. We are trying to take more care of the mental health issues to decrease this problem. So we have different policies and guidelines that are intended to be updated and aligned to the national strategy. And something that is really working is that from the point of view of prevention and promotion, to make an approach every year, a medical assessment, and that correspond to also to a psychology test. So we have this advantage for detection on annual basis through psychological assessments. And it has helped us to intend or to have some prevention measurements in order to enable the military person once the psychological assessment has been made. And then we make a link to the medical unit to the where the military correspond to, and then using participation, we see the place where his family is located in order to know the scope of the mental health coverage. Through the operating manual of mental health for the Mexican armed forces, we are trying to implement this strategy mostly for prevention and promotion, where we are jointly working together with the army, because they are quite similar, or their blockage or all the similarities that we have regarding mental health. And this has been helping a lot to improve training for the mental health staff and to renew the programs that were not updated regarding mental health. We have three very important areas where we are focusing our efforts. I think this is quite similar to the universal. We have, for example, the suicidal behavior, stress, post-trauma. These are the main topics why we have implemented different programs. In these strategies, our guidelines and policies approach what Mexico is looking for, and this sectorial plan for addictions and prevention that is being starting in our country has helped us a lot to align our own policies in terms of human rights and to update and to do some research. We have different purposes that we have set in the Marine. One of them is to know more about these problems in order to know what are the measures or strategies to be implemented. From the point of view of promotion and prevention on health, we have some statistics that we already have, but sometimes it is not all analyzed or used. And this is what we have been using for this alignment. we still have some goals to be reached, and we are working to recover the mental health on our members and their families. Now, I would like to thank you and to continue fighting these mental health issues. Thank you very much. Doctor, thank you very much for the challenge and all the efforts that you have been doing and which you have shared with us. Thank you. Really, thank you very much, because in all the places where our leaders are located, each one of them have a significant challenge. For example, now you just talk about the stigmas. Dr. Lore also talk about it. It is a topic that is a novelty. For example, that you have a double stigma. But finally, by joining all our efforts in this sectorial program, we can be in communication in order to cover different fields and different parts of the territory. This has been very significant to provide a better response. You mentioned three topics that are very important and relevant, which is suicide, consumption of substances that we have all addressed, but you also mentioned the post-trauma stress, because we had different experiences, and we are still working on that by providing an emergency response to each one of those scenarios. And to that extent, fortunately, we already have these strategies for the education and the formation process of the resources. So we want to thank your participation. Afterwards, I didn't mention this before. We are going to have a question and answer session so that we can present in the best way each of the questions to the people providing their presentations. Now, we are going to have Dr. Lucia Ledesma Torres. She has a doctorate on the neuropsychological changes in patients with psychology pathologies resistant, submitted to functional surgery, stereotactic specialist on behavior, psychopathology, and cognitive stimulation of brain damage, master and post-degree on clinical and psychology of the health, bioethical neuroscience, among others, and a specialty on the clinical area. And her professional path is a member of the neuroscience committee, professor on medical residences for psychiatry. He is responsible on the psychological clinical in practice at the UNAM, and the thesis reviewer at UNAM, teacher at the Upper Medicine School at the Poly and at the Pan American School in post-degree on the medicine and neuropsychology and mental health of the ISTE, and currently she is the director of mental health in ISTE. She is responsible for human support for sanitary staff. Go ahead, doctor. Thank you very much, Dr. Salina, and thank you very much to the audience that is following this third International Congress on Mental Health and Addictions. And I am really very glad to share with my colleagues with whom we had shared some other moments, because we are working together in the sectorial work and with a shared support in the different entities. Right now, we are going to present regarding the sectorial plan on mental health from theory to practice, which was the experience on ISTED articulated with all the efforts made to make an international congress. Well, I would like to devote some minutes to say what is ISTE. ISTE already has a tradition on social services started in 1959 from the 60s up to now, where we put together the health service and social, cultural, and economic services to the benefit of the state workers. As such, we have a coverage that is all close to 14 millions of title holders for services, medical attention. And regarding the medical units, we have more than 1,121 medical centers distributed on all the centers. I mean, from family clinics, hospitals, clinics, hospitals for surgery, outpatient services, high specialty centers where we provided these services. And it is very important to mention that we have an estimate of about 7% of the title holders with requirements associated to psychosocial disability, associated to mental health. And as it was mentioned in this Congress and in the prior emissions, the big problem resulting from the pandemic situation in all the world, especially in Mexico, in such a way that in the East case, we started a reformulation process aligned to the international reformulation for the mental health, where one of the main purposes pursued in the world is to decrease and to decrease the mental health gap, as Dr. Lorena mentioned, the importance of taking these services to the first level of a service to the community, and also to be aligned with different of the components that make better the concept of mental health, and which has to do with the psychosocial welfare and to social peace conditions, among others, where from these basis we are approaching the problems regarding the mental health. It has mentioned that one of the strategies that allowed us to approach as a sector to promote this mental health is the MHK strategy. In such a way that in East in the 2019, we started the reformulation of the mental health and prevention in the story of the Institute under the leadership of Dr. Elizalde, our director, doctor, to complement in the agenda of the institutions this mental health service and to start constituting it formally. Of course, we had this pandemic that left this important gap where the institute is developing interventions on this regard. Here I am going to show you a brief video where these interventions are trying to have an international projection with two strategies incorporated. It's COVID. It's providing some services using dogs with more than 120 units. And we had a very good response from the staff. Sorry, doctor. Sorry, doctor. This is one of the hospitals with more areas devoted to COVID. And we also included these robots to improve mental health services. This was a push to what we started in 2019 by integrating this mental health program. But historically, on March 2021, we approved this program for the mandatory implementation in all the units in the country with a modern approach, with an integral approach, aligned to the international programs on mental health, and also taking care the 3 levels of attention, associating the mental health component to the outside interventions in the community, and with an important intervention that was incorporated in the primary level of service, because sometimes we are limited in the first level. But in the case of the Institute, we are already working since several years ago in all our medical units. All this with an approach where strategies are addressed to have an inclusive strategy, and also to consider mental health in a more integral way and entirely abiding to human rights, from the theoretical to the practice. We already have, for example, the publication of Guide 1120 in the 2021. The first day when it was published, we started the implementation, and from that date until today, we already have this mental health included from the first level of service. We have two specialized units on mental health in the general hospital. We reach more than 170 beds incorporated to the general hospitals. We also have hospital clinics with mental health beds, also in our regional hospitals, in general hospitals, specialties, and also taking care of mental health contingencies. We enable again the clinic that we have. It is a unique one. We created a mental health center and palliative care that has been in operation 2 years, that allow us to implement this mental health program. Something else that is important that was already mentioned by Dr. Lorena in 2022, we still have some sectorial actions, and this is strengthening us as an institution. And one of these outcomes was the publication of the reform on mental health in May 2022, where we can see important items such as medical urgency on mental health, immediate response in crisis situations, eliminating the psychiatric model, and to move to a mental health model, as mentioned, to increase the legal capacity for users on mental health users. It also provides us some overviews regarding the attention in the general hospitals, emphasizing the attention to children and adolescents. And this is very important regarding psychosocial distress, and it stresses the right of users about being taken care on mental health issues. In the same year, in the 2022, the National Commission on Human Rights positioned itself making a reform to the general health law and incorporated it in all the sector, including, of course, ISTE. In the 2022, likewise, we made a sectorial alliance. In the 2023, we incorporated to COES, to the sectorial plan on mental health, and we started to work the mental health and addictions program, where together with our colleagues, finally, we implemented it by adding all the experiences from all the units, and this allowed us to align the policies and strategies to whatever is working best in each one of the entities. And one of the important doors to configure this articulation were also the working sessions associated to this Congress and to these encounters in the different editions. Here you can see the presentation of the sectorial plan and the addiction prevention with the representatives of each one of the entities, with the attendance of the Ministry of Health. Part of these workshops, well, these are the final images, but this is what was included in the document that is enforced in all the entities of the country. These are part of the workshops formed in Durango for the meningitis problem. It was an interdisciplinary work that took days, weeks, and months. Here you can see some of the images of the different representatives, Dr. Norma Palacios, and our colleagues from the Ministry of Health, the CONASAMA, among other colleagues that added to the interventions in situ in situations of contingency and health emergency, where we include the topics of mental health for its solution. In part of the works that were done by the IMSS Bienestar regarding training, exchange of experiences, the goals that were developed on that regard, also the visits that we've made to the different centers with our colleagues from CISS that accompanied us in the sectorial plan. And this is one of the several days that we were working. This is an image on how we discuss the sectorial plan on mental health and addictions. And regarding the East experience, we are ongoingly working. We have more than 300 community health centers working on self-care, not only on the theory or by publishing the guidelines, but taking it to the practice with several strategies for the users and committing on the health professionals, and part of the activities that are done along all the years on physical activity detections associated to risk factors on mental health issues. Here you can see how we work on these campaigns 3x1, the campaigns to prevent the heart strokes, and also associated to exclusive policies, gender equity, and self-care. The one that was made in the metropolitan area, for example, in the dependence column, because we do these walk-ins once a year together with other activities. This is part of the National Center on Mental Health and Addictions, and also the palliative care by incorporating this mental health program for residents and ISTE staff, because we already have some years of experience, and also these dog-assisted interventions with the publication of guidelines for self-care care and mental health of the children activities, because these materials with their implementation reach 250,000 schools. Likewise, we are also working with the communities regarding the policy to establish a healthy working community using our dog therapist. We already have this experience in pediatric oncology. As you can see, the works performed since 3 years ago in labor communities with administrative spaces. As we still have this emotional aid provided by dogs, and it is made by the staff that was taking care of COVID. And we are going to have some dogs invited to this Congress in the clinics to stop smoking. We have a tradition over 20 years. In this phase, we have more than 150,000 services to stop smoking. We provided a lot of treatments. We have the San Fernando Specialized Clinic to take care of people living with HIV. This is part of the images of the interdisciplinary work performed. And we have high specialty programs for the third level of attention, such as the orphan strategy with the interdisciplinary approach. These are some of the images on the 20 de Noviembre hospital. We have mental health attention for migrants because we have been working with them in the Istmo at Oaxaca area. How we are working in the 35 representation in the more than 1,100 units that we have in the second level of attention with the integration of medicines and beds at the second and third level of attention. Also special protocols for the treatment of patients with severe and resistant psychiatric symptoms, the collocation of neurosensors with a minimum invasion. Here you can see the presentation of Dr. Elizarde regarding the palliative program, which is articulated with the mental health program and with which we are also working in all the country in our more than 1,100 units as an innovation only at the third level of attention, but also incorporated since the first level to incorporate vulnerable groups since the very first contact. Regarding manipulation and guidelines, we have more than 30 guides published, 3 of them associated to mental health. The municipality agreements that were made from the medical management for community intervention on mental health, our participation in the open forum for and also working how to train the people. We already reach more than a lot of people trained. We also have the advisory services for the first level of attention. 2 years ago, we already have public health incorporating mental health, which are made inside the institute to strengthen all the actions in all the country. And in our virtual school, we have 30 courses along the year where we update permanently our staff. Of course, including mental health emergencies and first aids, which are also according to the mental health and addictions plan. Regarding infrastructure, we have just 30 seconds more. Regarding the adaptations that we made in the general hospitals for the attention of our patients at the toxicology center, providing advisory service nationally. One of the main reasons for these advisory services are suicide, and we are covering all the country. Part of the notes that were emphasized at the work level are the committee working in Guerrero. Here we can see Marisela Sandoval, doctor, and finally we concluded today this recognition of the purple ribbon, and it was regarding the service provided on mental health emergency. Well, there is no health without mental health, science without coins. This is important to be considered as a ruin of the soul, and that is why we have to implement all our actions, because this is one of the most tangible products that we called United by Mental Health. This is part of our group. And of course, we would like to thank all the teams following these presentations and this Congress in all the country, which are the essential pillars of the Institute for the actions regarding mental health and addictions. Thank you very much. Thank you very much. I think that this was a very good presentation with the history, with a lot of experiences about the institutions. We are very glad to know that this mental health management has
and it's great
adopted
to know that
this
you have
place.
gotten this role to answer back. And it was also very moving, personally speaking. All of the things that you have implemented and how amazing it is to have the evidence that you can also bring to this checkout and to share with each and every one of us. Thank you, doctor. Now we will have, I would like to bring to the table this very important person, very loving and very loved and very important, Dr. Magdalena Palacios Jimenez. She has a master's degree in education and innovation management, some postgraduate degrees in distance education, online education, and management. She has a specialty in infectology for adults from La Raza and the Mexican Institute of Social Security. She has a specialty in internal medicine from La Raza as well, the same hospital. She is a surgeon from the University of Guadalajara, Mexico, and she is currently the chief in the project management area for health projects in the coordination area of the Mexican Institute of Social Security, IMSS. She's the one responsible for coordinating the comprehensive mental health program since 2021 to date. She is currently the head of the coordination of education at IMSS, as well as the head and coordination of educational innovation in IMSS. And she is currently holding the position of mental health and addiction coordinator of IMSS as well. And she will be giving us her presentation. Thank you very much, Dr. Salinas. And thank you very much, everybody, all of our colleagues that presented before me. To me, it is an amazing and exciting experience to be here with you. And I'm also very excited about seeing all of these very invested people in mental health matter. It is very exciting to see how many people were brought together, how many people were interested in knowing what we're doing. So personally, I feel more committed. My hands are sweaty because I think there is so much to do still. So I really appreciate the opportunity to share what we're working on in the Mexican Institute for Social Security. I'm going to show my screen. I'm going to share my screen. So I believe it's always relevant to provide a little bit of background, a little bit of context, and some data when it comes to what the institutions are doing. I am going to be talking about what we were doing and how the sectorial plan becomes a relevant support to strengthen some strategies inside of the institute. At IMSS, according to the last report to the President's office, the mental health matters have increased when it comes to appointments. And as you can see in this last report, uh, mental health issues and behavior. In the previous report, it was number 10, and it currently holds number 8. And when it comes to specialty appointments, in this last report, we realized that there are the 6th reason to come into a doctor's office. However, it is also very interesting that everything around poisoning and trauma comes in the first numbers. And within the challenges that we have, and just like mentioned by Dr. Lorena, we're looking at an improvement in our records and being able to properly identify the situation, because a lot of the cases of suicidal attempts or behaviors are nested there and it's hard to make a difference. To the right, you can see where we are at when it comes to the specialized staff, because this is also a relevant point for the work that we're doing inside of the Institute. And as you can see, just like the rest of the world and the rest of the institutions, we have lacking in staff, specialized staff, when it comes to psychiatry and psychology inside of our institute. However, another relevant factor that's also very frequent is the staff to be full on located in the large cities, and the faraway places and remote areas don't really have the access to this kind of staff. You know that IMSS it's quite large. They are providing care to over 60 million people. And the institute, from infrastructural perspective, it has over 500 units for the first level of care, 250 hospitals, 25 high specialty medical units, and 11 complementary units to the high specialty medical units, which is third level of care. Within this, we have three psychiatry hospitals, and within the 250 hospitals, we have a psychiatry hospital that's considered to be second level of care. From a human resources perspective, the highest amount of staff that we have, it's nursing. We have around 120,000 nurses, and MDs, we have maybe 20,000, a little bit more, and over 40,000 non-MD doctors, which is essentially those doctors that hold any sort of specialty besides general medicine that are working at hospitals, and we have over 50,000 social workers. From an infrastructural perspective, IMSS has over 7,000 offices for general medicine, 6,000 offices in hospitals, 932 continual medical offices, 617 ER areas, 2,686 preventive modules, 1,000 modules for the specialist in family medicine, and 139 modules for health promotion and prevention for the workers of the Social Security. Of course, this is important data for us because it led us to define what was going to be the route that we were going to follow inside of the IMSS after the lack of specialists. So it was relevant for us to start working first in designing a model, defining a model for mental health care, and based on this model to understand what's the path to follow. So we identified as priority having the opportunity of standardizing and harmonizing the side of treatment of the main mental health issues, to develop skills from on the staff from the first level of care, and start working the biggest challenge, which is enabling spaces in the ER and hospital areas for the care of mental health issues as a first step of suicidal behavior, as well as addressing a plan, creating a plan that addresses emergencies and suicidal behavior. So we are very aware of our situation and the features that we have inside of the Institute. And also based on all of the international recommendation and the federal programs, it was important for us to start working towards changing the model, the current model of mental health, where everything is focused on the psychiatry hospitals themselves, to start to define and set strategies so we can provide community-based services for mental health care, create these services in general hospitals, and bringing in mental health in the primary level of care and any policy plan or intervention that's done inside of the institute, as well as promoting self-care through information. We need to educate the population. Yesterday, I absolutely loved some of the interventions that we heard, where they were saying that mental health was everyone's responsibility, as well as fostering the interinstitutional and intersectorial collaboration. Just as has been pointed out before, we have clear gaps in the mental health and addiction care. We have four large gaps that have also been defining internationally, and that every program that has been created on a federal basis, they have addressed, because this is the base, the foundation to design the different interventions that have to be carried out inside of the health sector. The first one is the lack of stewardship that we have been working on. The second one would be the lack of specialists in mental health. The third one would be a lack of service to care services. There are some cities where hospitals are might not be properly placed. So there are states and regions where healthcare access is very complicated. And the last point would be the lack of research and high quality information so we can make better decisions. In 2021, after all of these background and adding the COVID factor in 2020, the Institute created an action plan to address the mental health issues during the contingency and the pandemic. And we oriented the workers, and it was operating in 2020, 2021. However, in 2021, we have these comprehensive mental health programs from the IMSS so that we can state a roadmap, a critical roadmap on the next steps to be taken in the following years inside of the Institute. This program picks back up everything that we have already mentioned. We have to have an honest and sincere diagnosis of your own institution, and of course, reading and understanding the international recommendations, as well as knowing where does the sector is heading, and bringing to the table everything or an approach that could entail everything that we have mentioned before. The first priority objectives, it's systematizing the care and promotion of mental health in all three levels of care to increase the mental health and addiction services and grant an equal access to these services. So in the program of 2021 to 2024, we understand that this is going to be cross presidential terms, because it's going to be impossible for us to achieve all of the targets in lesser time. We have 7 strategies for this plan that are highlighted here, and we were thinking about 18 action plans. What do we do once we define this program? Well, the first thing that we that deemed relevant was focusing on detection, being able to standardize a tool to be applied in the first level of care units. And this was the first job, defining a technical team, defining a tool, the proper tool. It had to be easy to apply. That would allow us the identification on the suspicion of depression or anxiety, as well as panic attacks. What we did was training the nursing staff. This was very close with the nursing coordination and the first level of care units of IMSS. We got to train the staff, and we started the implementation of this tool so that we could get an earlier detection of these two issues that are the most common ones at the IMSS. As part of the work that deemed essential inside of this program was having a census of the people, quantifying census of the people that might have mental health issues. We work with the epidemiological surveillance coordination and IMSS, and we managed to define a methodology to extract the information from the different systems. So regardless of where the person would come from to receive care, we were able to integrate and identify all of the users that were uh, going and trying to receive care. And now we have a 2019, 2020, 2021, and 2022 census. And this last one showed us a record of 3,374,000 people. So what's the most common thing seen in the census? It's anxiety issues, up to an 81%. And second level, we have depression, depressive episodes. And what we have seen in this 4-year comparison, it's an increase on those issues derived from substance abuse. The average age of the population is 39 years, and we have more women than men. After the deployment for the detection of the main mental health issues that we managed to standardize and the application of this survey, there are still some action areas to address. There are some aspects that we need to work on, mainly the proper recording and interpretation of the tool itself. We managed to have over 3 million detections nowadays that has led us to a proper identification of these people, and so that they can be addressed to the medical doctor, to the general doctor, so they can receive a treatment from the first level of care. In order for us to strengthen the capabilities of the first level of care healthcare staff, we started working with the AIM-H gap system with CONASAMA, PAHO, when we brought up the need of being able to develop this training internally. There was a lot of support from their side, and we developed this training with the support of the Economic and Social Benefits Association that helped us with the funding so we can develop this training. We carried out this training that was implemented since September 2, 2022, and nowadays we have over 30,000 healthcare professionals that have been trained. Some other people mentioned that just so we can have a better diagnosis of our progress when it comes to mental health, we brought in the mental health component to the stewardship of the security, the IMSS board, and essentially this was born since COVID, but more priorities were added. And last year, on November 9th, they integrated the mental health component. So, as an outcome of this need that was recognized by the Institute of Understanding on a sector and regional basis that the IMSS was already working in a more comprehensive and organized way, and that there was a program in place, we carried out the first and second Mental Health Congress. Last year, we also saw the relevance of starting to work anything related to suicidal behavior, and we carried out this action plan that is composed by several elements. Some of them are the informational campaigns to raise awareness in the population. The population needs to know about this mental health subject in general. They have to understand how to better take care of their mental health and how to prevent or identify if a person has a suicide behavior. We developed two guidelines that was very important to harmonize the work that's being done in mental health aspects, one for one for minors and one for adults. And we also started the implementation of a specific protocol to be activated when we have a person with suicidal behavior. This is a work in progress. We already trained around the guidelines, and we still yet have to work on the protocol for suicide behavior. Another point is the quality of information. It's also very important in the registry to properly capture the information that's generated and to have proper mental health networks across institutions by state. This is one of the biggest challenges that we're still working on. And having an educational plan for the healthcare personnel and develop some research and research networks. These are a couple images of the guidelines and the self-help guideline for mental health, and this is available for the population. Now, when it comes to the sector plan, we have two excuses, so to speak, for this plan. One is the integration of the mental health component within the stewardship and the board, and that within the aims we deem necessary and urgent to have a closer work and a closer collaboration to properly integrate true mental health networks. Because we have some states where we essentially have voids, and there is no way that a person that might be facing an emergency or a suicidal behavior could receive proper care in a timely manner. So those were the two main excuses why we wanted to develop this plan. And the key points of this plan are essentially that we deem urgent and necessary for all of the institutions to have a um, proper board and management system around mental health, that this was molded around mental health first to define the model and then develop the guidelines to work on the skills of the healthcare professionals, either specialized or not, and the promotion and fostering of the self-care in mental health to have mental health services available in general hospitals, the intersectorial and cross-sectorial collaboration, and the integrated networks for mental health and addictions. We have a general objective and for specific objectives, I'm going to highlight the specific ones. The first one is to improve the exercise of the stewardship. The second one is the design of an educational plan. The third one is increase the quality of mental health and addiction services. And the fourth one is improving the quality of information and research. If, as you can tell, the specific objectives are aligned with the gaps and the recommendations of PAHO and the WHO, and they're obviously aligned to all the work and efforts done by the sector to move forward in this matter. What did we do at the IMSS when we carried out the sectorial plan? We started working on January 17, 2023, and we finished it on March 18, 2023. We enforced these, started enforcing this plan on July in the Konasama Institute. And this was the first objective that we addressed, improving stewardship to provide a vision and direction on the health system when it comes to mental health and addictions. First, they integrated the institutional structure for institutional programs, and the Technical Council of IMSS approved the creation of the coordination in mental health and addictions. This is a great institutional success because this allowed us to organize and coordinate the job that's done in all three levels of care when it comes to mental health and addictions. And the second point that is also aligned to this first objective is the definition of the institutional guidelines. The first thing that we do, the first thing that we did was in the organizational manual of medical care, which is the manual that every structure has. We specified the actions of the coordination of mental health and addictions. This is soon to be published, and you can check the responsibilities of this new coordination. We also developed a bill that state the provisions for the proper healthcare of mental health and addictions at IMSS, which will help us to define what the three level of care needs to do when it comes to mental health and addiction. Bearing in mind now the second objective that was related to the educational plan, there were some actions that we were already carrying out, like the standardization for the detection of the main health mental issues for the nursing staff in family medicine and the prevention modules. And that was the application of this tool for the population over 20 years. And we carried out several training efforts that you can see on screen. And after this large amount of nursing staff that we have, we had a progress of 35% when it comes to training. Now, about the development of skills for the first level of care personnel, we need to properly train them. We need to perfectly outline what are the skills that we need from the staff and the first level of care or the first contact. And the first thing that we do was working in the training of the MD and the general medicine doctors that are part of the guideline of the MHGAP guideline. We also started the integration of a community MHGAP, especially for the social workers, so that the staff, the psychology staff, and the medical assistant. And this training is actually open for anyone because anyone, including the person that's under surveillance, should be trained in this matter. And what we also developed was a proposal called Milestones or the MHGAP Pearls to overview the implementation, because there is no point in having these millions of people trained if you don't see the practical side of what the staff learn in the theory. So what we did was defining these through seminars and achieving the practical application side for the intervention guideline. Now, when it comes to the ER and emergency care, we were looking at the proper skills for addressing suicidal behaviors. We carried out a training of the operational staff for 2 months where we were training managers, hospitalization, and operations staff to understand these guidelines. We still have a long way ahead of us. We still need to work on this. It's not enough to just have a training. That's why the verification and supervision of the field is very important because that's how we get to the specifics. Now, we have also fostered the prevention in the PAHO training that's called Prevention of Self-Harm and Suicide. And with Kanasama, we have been working closely so we can look at the training that they currently have when it comes to suicide prevention. It's also very developed, but that we want to make some adjustments too, especially for the ER services that based on the time and features, they do have to be very focused on this training. And another progress that we did, another achievement that we did was the development of brief interventions where we carried out a design with the educational health education coordination so we can have brief interventions in counseling. Now, as part of the plan to increase the quality of the services that are connected to this objective, and the core is its core would be the promotion of mental health and addiction prevention. We released this sector campaign. I'm sorry, I just wanted to mention that you have a few more minutes left, of course. So we launched this campaign in social media, printed media, and digital media. I believe it was a successful campaign. And we have some matters that still need some work from a perspective of a better assessment of the scope. But this is a campaign that should be permanent. The other thing that we do was a sectorial work as well for suicide prevention. This was also launched in social media and digital and printed media. And I want to highlight the work with the stewardship. This mental health component has been very important because it has allowed us in real life to know if what we're saying in theory or from the planning side to actually be enforced in the operational side. And we managed to have a comprehensive assessment of the mental health issues that are being cared for in the first and second level. The components that are being assessed are the promotion of mental health and the detection of mental health disease in a timely manner, a confirmation of diagnosis and treatment, if they're actually applying the intervention guideline MHGAP, if they're applying the guidelines or protocols for the addressing of suicidal behavior with the different codes that are already out there, because we do this cross-sectorial, if there is an enabling of the mental health areas and the degree of advancement that progress that we have in training. The challenges are many, but essentially for us, it is to land the guidelines to have aligned protocols to improve the promotion of mental health and addiction prevention, to have a proper detection of mental health issues along the life cycle. We are now focused on a specific age group. We're looking at the application of the guideline of MHCAP to improve record and data gathering, training in ER, traceability in the mental health process to have real clinic and population-based research. And I believe the largest one is to have the operating comprehensive networks of mental health and the protocols before emergencies and disasters, so we stop working in a reactive manner before any situation that is out of normal. That would be it. Thank you very much. And I'm sorry because I overstep a little bit in time. No, it's fine. Then again, we really appreciate the work that you have carried out, not only in your presentation, but also how you manage to coordinate and communicate, as well as develop this matter. It we have been working, operating a long time without a coordination for mental health. And luckily, we now have Dr. Palacios as the head of this coordination. This is a big push forward to all the work that you mentioned before. And honestly, it sounds really easy, or it could be deemed as very easy to bear in mind this structural issue. It took long enough, and luckily we made it, and this has been done in an exemplary way. Just like Dr. Lucia Ledesma mentioned, what the work that has been done inside of both institutions are amazing. We need to mention that we have the operational, technical, and strategy-based matters. And it's amazing to see that you have addressed all of this and that you have visited some places and you faced many challenges and that you have also taken the lead. We have very little time. I don't know if Dr. Lore would like to say anything about the strategy once it reaches the different places and you notice the lack of care for the population. Because then again, hospitals, we have the stewardship, we have the manuals, we have guidelines. We realize that you have tried to keep this vertical structure and to provide follow-up to the strategies that we have mentioned before, but it's also about the field vision. Maybe these could help us enrich this panel. Dr. Lore, would you like to mention? And our panelists, if they have comments.
Okay, thank you very much, Dr. Salinas. It is very important to understand first that our country has a lot of realities that before going to the territory, we must know specifically which are determinants essentials in health predominating in those places. One, two, which is the causistic locally, the main mobility reasons, as well as mortality, which are entirely mandatory regarding these attentions. And second, the access before going to the territory. I mean that the critical route must be thought before going to the territory. Why? Because this will allow you, the more information you have, you can generate in situ a lot of strategy to sensibilize the staff located in the site. What we found is precisely that decision makers on site, I mean the directors of the hospitals, the first resistance to implement these services in the hospitals, mainly because they think that they are going to have a mini mental health hospital there, that they are going to be receiving all these mental illnesses. And second, that they have the idea that the attention groups for users on mental health and addictions must be entirely different to the rest of the users, when we know that, yes, we have to take some provisions, evidence show that we must enable certain things in those spaces, but in fact, the attention must be provided as it was provided when any other emergency on health arrives, because suicidal behaviors, abstinence syndrome, psychotic episodes, worsening or of anything else, it's an emergency. So we have seen that when you go to the territory, first you must have the entire context and the entire panorama of the place where you are going. And second, to explain to the rest of the professionals how health is really associated to many simple things. For example, the adherence to the therapeutical instructions. So, because we know that this is resulting in a very high cost and it's saturating their installed capacity, it makes that the people, the staff is entirely tired and that everything is not properly working. I mean, I think that the challenge is to take the time, well, first to identify what they are doing.
Estrategias facilitadores. Las enormes quejas que también de pronto hay es que tú solo vienes.
Because sometimes we have some claims because they say you just come here and try to implement that. Sorry. But
Es que tenemos que facilitar.
In fact, we have to facilitate
Facilitarles ser nosotros como entes rectores.
That we, as a regulating entity, we must be the facilitators in the operating processes. It is not only go implementing, it's working with them to design with them the strategy, to provide them with a attention flow, to make the risk analysis, to verify the need of competencies, transferences, to see if they are already changing the paradigm of the diagnosis in those places. Thank you very much, doctor. I think this is the time. I don't know if you would like to provide us with a conclusion. One of the questions that we receive is about the workers. Well, fortunately, we were able to be in those states, in those places. Dr. Lori mentioned that it would be impossible to make some progress and to provide an appropriate service if we do not take into consideration the attention to our own staff. But fortunately, each one of the institutions are accepting the challenge. Unfortunately, we already have protocols and a way to properly intervene in order to promote and to protect the population, mostly the health staff. Maybe at another time, maybe you can provide us with more experience. Do you have a conclusion in order to close this section, but a very brief conclusion? From ISTE, I would like to thank all my colleagues for the opportunity of working together regarding what we presented today. It has been so enriching, and regarding what Dr. Salina, Dr. Norman, Dr. Flores mentioned, the importance of going to the territory to leave your office back and really accompany all the different implementation processes. At least for ISTE, this has been a strategic element that together with all the mental health teams in the countries and by forming non-specialized staff for the first contact at the first level has been essential. And also, I would like to thank the emergency staff, doctors, nurses, stretch, because they have been also essential pillars to implement this mental health protocol purple ribbon, because we know that we have a lack of these specialists. We have more than 4,000 accumulated cases. We also want to thank all the personnel on emergencies, on all the first level of attention, by taking care of all our users. Thank you very much. Thank you to all my colleagues. Very interesting your work, Dr. Flores, in your environment with your own features. Thank you very much to you, doctor. Now I am giving the microphone to Dr. Flores to properly close. Please, Dr. Flores. And last, the organizer. Thank you very much. What I would like to emphasize and to recognize is the work performed by each one of you. It is very important to add all our efforts and to promote this impulse, because now we are seeing the mental health. We have to address it and to sensibilize, as Dr. Lorena said, to the decision makers so that this can be replicated to more population as more as possible. Because this is a work that we are all working on, and from our part, just to thank the invitation from the Marine, and let's continue working together. Thank you very much to you all. Thank you, doctor. And now, Dr. Palacios, and also to thank for the coordination effort and the organization of all the Congress. Thank you very much. Dr. Salina, Dr. Ledesma, Dr. Lieutenant of the Navy. I hope I mentioned your title right. And Dr. Lorena, thank you very much for being in this panel. Well, my message, I would like to say as a conclusion, two things. We must really be aware that the mental health issue is a problem for everybody. It's not only for the health professionals. We all must be involved in taking care of the mental health, first to understand better what is it about, and second, is that together we must break all the stigma that we have around mental health. Why are we not progressing in these initiatives? These are not technical issues. These are not professional competency issues. These are things associated to the fear that we feel when a person with a mental health condition arrives. I think this is a time that we, as the institution, not only the sector, but all the institutions in all the environments, add all the actions to break these stigmas, to work with our institutions in order to modify ideas that are old, preconceived, bizarre, that are not updated for the welfare of all our population, including one of these conditions, and to thank all the work performed by all the team, everybody working on this. Thank you very much for all your effort. Okay, thank you. We greet each and all the people attending these panels. See you back here. Thank you very much. Thank you. Have an excellent day. And let's continue with this excellent journey. We thank Dr. Luis Alberto Salinas Torres. We thank the moderator, Dr. Luis Alberto Salinas Torres, for this interesting panel that was from theory to practice. We are on time. We are giving the floor to Joaquin Castillo. As mentioned by Dr. Palacios, I am so emotionated by all the efforts made by the different institutions in favor of mental health. Now we are going to continue with our work program today. We are welcoming and we are introducing Dr. Carmen Torres Mata, that will be talking about the challenges and well done in the national strategy. She has a formation as a surgeon doctor by UNAM. She is a specialist on psychiatry by UNAM and the National Psychiatry Institute, Ramon de la Fuente. She's a specialist on childhood psychiatrist and adolescents by UNAM and by the Psychiatry Hospital Juan Navarro. And now she is the association director of the National Commission. She has been part of the national strategy for the prevention of addictions, and she's also the commissioner to the technical secretary of the National Board on Mental Health. Currently, she is the director of association on the National Commission of Addictions, CONASAMA. Let's welcome you and let's pay attention to you. Thank you very much. Before everything, I would like to thank the invitation to participate in this important conference. After that, the prior conference, there is a huge challenge also after the speakers yesterday. So let's take the best advantage of this presentation. I'm going to be sharing my screen. Or maybe you can help me on that because I can't do it. Thank you. Thank you very much. Okay. As mentioned, today is World Dance and Challenges on the National Strategy for the Prevention of Addictions. It is important to say that this national strategy for the prevention of addictions started in this administration with the President José Manuel López Obrador, and it was initially presented in May 2019, initially focused on the children and adolescents. However, when we review the work and the analysis, we couldn't put the young people and the general population aside. I mean, elderly, everybody. The main purpose of the national strategy was to impact the psychosocial aspect to reduce the consumption of drugs in the framework of the human rights, considering these two aspects as principal aspect, because this should not be only in the framework of the prevention of drug abuse, but in the framework of any law in our Mexico. In this first planning of the strategy, we called all the entities of the federal public administration. As mentioned before, the mental health and addictions is involving everybody, not only the health staff. In the first call, we had a very good participation by the Culture Ministry, by the Institute of the Youth, SEDATU, the Welfare, Social Security, IMSS, Bienestar, CEMAR, SEDENA, civil society organization. In fact, the people attending was excellent. However, one of the main challenges that we started to see in the beginning, on one side, everybody in a certain way were working on the prevention, understanding the attribution of each one of the institutions according to the vision that they have at that entity. And also, many entities did not have clear how, from their competencies that were not associated to health, they could prevent addictions. And then in this first journey, it was like just first talking about the objectives of the strategy. But when we saw these two important challenges, we started to see the one by one, the Ministry of Health, from the three National Commission Against Commission, Psychiatry, and the Mental Health, with each one of the entities involved in the topic explaining why these programs that were already in force, I mean these social programs, may be added to reconstruct the social fabric regarding violence, prevention of addictions, and mental health, in the understanding that, as mentioned in the prior table, were impacting the health and the access and the well-being of Mexicans. In July to December 2019, we started these planning sessions with the different actors. In fact, they were very enriching sessions to talk and to exchange ideas. And there we understand that everybody could be involved, but in an uncoordinated manner. And that was one of the main axes of this strategy. This is an intersectorial articulating platform. But we cannot put aside the state, municipal, and federal levels, because as mentioned by Dr. Lorena, we must understand the adequations to be done in the territory. I cannot do a shirt that fit all the states in the country, because realities are different, cultures are different, the vision is different, and then I have to understand the needs. Then one of the good parts of this strategy is that we have a federal and state and municipal coordination, so that by doing the appropriate enhancements, we may start managing all these changes according to their needs in their populations. As I mentioned, the social determinants are very important, understanding that in many prior approaches we have considered the addictions problem from a safety perspective, a criminalizing perspective. But it is a public health problem where we have to listen to everybody, regardless where they are. Yesterday, I saw in some comments that they were saying that there were different profiles that were taught regarding health. And I think this is an important part. We have to go as a health staff and say, okay, I am the expert on this health issue, and I am the one who has to do all the work, and other profiles and other entities do not have it clear. But in fact, all the work must be focused in enriching other visions, because it is not only one vision that is appropriate of the right one. We must understand that the civil society must participate in public policies, but also from other entities, from other profiles, with an active participation on this regard. That is also another good thing. Visibility as a problem of health. We cannot be intolerant to the visions of others, of course, according to the human rights, because sometimes we have some problems with some entities, but we must start learning from each other. We must make an exchange with other entities, because this is another strength, because we must say, okay, this is our vision of the public health, of mental health, but not centered only in us, but more widened with other narratives, with other methodologies, because when we are health staff, we are not educated in a social context, in a wider context. Sometimes there are some places where we can have an impact, but some others are a challenge, and this is one of the difficulties for the continuity of this strategy. Among the first actions that we started to do was a sensibilization training at different levels. We cannot think that only one training is going to be wide enough for a decision maker, a president or a governor, or for the people working on social matters, or for a teacher, or for the parents who are responsible for the general population. In the understanding that we have to homologate our vision that we have on mental health and addictions, in the 2019 we started this first journeys with two essential actors, the Ministry of Culture, the Ministry, the Youth Mexican Institute, and the Social and Safety Ministry. We started to work with this program within HUBE, with the Youth for the Transformation, with culture, with the reflections and other methodologies through the community culture program to strengthen the people working in the territory, in the field, and not less important, the Ministry of Security, in order to help them to move to different profiles that are wider, in order to get more tools and to provide them to this staff. Likewise, we started the training for the health staff, not only doctors, but psychology, nurses, etc. With this tool that we have been talking about yesterday and today, a program to reduce this gap on neurological diseases and consumption of substances. Why is this tool important? Well, as mentioned in the prior panel, do not have enough staff. We are only quite a few for the immensity of 130 million Mexicans, and we have to take care of all the resources in order to put mental health and health available to everybody. We started to train the people head to head, and it was not easy, but now we have these technologies, and I think we are going to be talking about this tomorrow, about these platforms that allowed us to provide this training to more people, where we have about 136,000 medical staff. I do not have to be the specialist. I cannot think that access is only for quite little people. Before being a specialist, I have the knowledge to take care of the most prevalent conditions, which are diabetes and hypertension. Regarding mental health, it should not be different. As a general practitioner, I must have available tools that will allow me to provide initial treatment for prevalent mental health issues, anxiety, depression, or healthy lifestyles in general to help the people in my community. Another good thing is the synergy of the federal actions, because we also understood that we had these very little efforts that were not traced or dimensioned according to the possibilities of how we could work with them. But then in these meetings, we understand how to do it, and also to work about the safety of our teams in the field. Regarding addictions, we understood that this is not confrontation. We must also understand, because discourses are very different. We must even change our vision as health service cares. We must understand that all the entities to have a better impact on the community and to learn from each other along this journey. Next one, please. This was translated since 2019 in actions in the communities, actions in all the national territory. We have actions that were made in Mexico City, as well as in Quintana Roo, in Oaxaca, in San Felipe, in San Marcos, in Guerrero. We still have a lot to do. We can say that we still have to do a lot because the need that we have on this matter is so big. However, the effort was made and actions were really very nice on the sports and cultural activities, reading clubs, and the different visions, strengthening the sense of belonging, the sense of community, conflict resolution, being them self-managers.
De salud mental si no dotamos de herramientas a las personas para que cuiden su propia salud, incluyendo su salud mental, ¿no?
Including their mental health. So this is obviously quite a challenge because it's not only about time availability or opportunities like we heard yesterday. There are other challenges that sometimes limit the access to certain services and needs to be covered. And that is where we have to look for a way in how to eliminate these barriers and how to be enabling agents so that people get to develop in their community, their environment, and make the best out of the resources that we have, not only in government matter, but also in the civil society. Next one, please. It is also important to mention that even in COVID times, we didn't stop. It made us rethink how could we move forward, and it also opened doors to new opportunities and institutions to work with. Leading the subject of mental health from the afternoons that we were holding, the afternoon meetings that we were holding with Deputy Secretary Gatel and with the DIF, we were looking at how to reconnect emotional management, what to do during the pandemic and whatnot. So obviously also talking about relevant matters like misinformation out there from the drug side, more than one perspective of youth. It was harder for some of us to understand those perspectives, and it is also important to understand these dynamics and these changes. Youth as subjects to the rights and participants to public policies, as well as hearing their needs and how we can meet their needs. We also held conferences in different universities, including the Guerrero Autonomous University, to discuss these subjects. And the participation and interest of the youth has been great. To be honest, the youth, it's a factor that I find very admirable because they're a lot more sensitized to these matters of mental health and substance use. They are more willing to raise their hand, to raise their voices as well, to be heard in manners that might be uncomfortable for many of us. However, I do think that they are better prepared in these matters than other generations, including mine. So it is important to bear this in mind and bear in mind the strength from the youth to take action in this matter. Next one, please. So with this strategy, in September this year, we, in matters of prevention, we reach out to 39 million people. Strategies that every ministry has. There is not a single path, but many ways where we can address from our own place the situation. I could mention the fairs and the volunteers, volunteer jobs that are centered around peace fostering and emotional management. We also have the creative seed planters, so to speak. They carried out an event recently in Auditorio Nacional where they brought children and teenagers from all across the country to their presentation. They are also doing healthcare promotion and substance abuse prevention through sports and rescuing spaces and Sedatu, and of course, through the care that we have to provide as health units. Next one,
¿Cuáles
please.
son los retos que enfrentamos?
So what are the challenges that we
Híjole,
face?
podría
Well,
decir que a pesar
I
de
could
que ya
say
llevamos
that
desde el
despite
2019 a la
us
fecha en esta materia,
being working on this since 2019 to date,
situaciones de
there's still
estigma, de
many
discriminación,
situations with discrimination,
del que lo
stigma, and the
reconocemos
visibility
como
of
un
the
problema
addiction
de
issue
falla
as
moral,
a
tema de que
moral
son las
matter
personas usuarias de
or
sustancias
these
psicoactivas
substance
criminales, etcétera.
users,
Entonces,
criminals, and
todavía
whatnot.
nos falta esta
So we are
sensibilización,
still
este
lacking in
cambio
this
de chip,
sensitization,
podría
this
decir, ¿no?
change of
Yo
mindset.
diría, primero, a todos los servidores
I would say
públicos que
first
estamos
to all the
trabajando,
public
¿no?
servants that are
Porque aún
working,
tenemos
because
creencias,
we
aún
still
tenemos
carry beliefs, we still
situaciones
have
que nos
situations
limitan en nuestras
that are
funciones, ¿no?
limiting in our
Y que bueno, es
jobs.
sentarnos y
And
escuchar
it's a
y
matter
poder
of sitting down,
ayudar a esa transición
listening,
de esa visión.
and
Pero
helping the
también
transition of
es
this
en
vision.
relación a la
But it
población,
is also
porque
about the population,
muchas veces todavía
because
se
it
percibe
is very
que
often
el consumo de
that
sustancias
we
es
see
igual
that
a lo que
substance
siempre tratamos, lo tengo que
abuse, it's,
internar
oh, I
porque
have
no
to
puedo,
treat
¿no?
them, I
Y en
have to bring them
realidad
to a hospital because I
tenemos que
cannot
verlo
deal with
desde
them.
una dimensión
But we
mucho
have to
más amplia.
understand this from
Muchas
a
veces esa
further
visión
perspective.
limitativa
And
de
this
adicciones
limited
es igual
vision of
te voy a
addictions
llevar
equals, okay, I'm going to
a un
take you
anexo, ¿no?
to
A
a
un
rehab
internamiento
center
involuntario.
or
Entonces,
any
estamos
sort
hablando
of
de adictos.
involuntary
Entonces, es importante ayudar a las
hospitalization.
personas,
So
a
we're
la salud
breaking the
general,
rates. We need
entender
to
que el
help
consumo de sustancias es un
people, the
fenómeno
general
multidimensional.
population, to
Y
understand that
entonces vale
substance
prevenir
use is a
antes de
different
tener
phenomenon
una
to what they
situación
think.
en
So it's
casa,
better to
¿no?
prevent rather to
Y
have a
lo
situation
que
at
voy a
home.
decir, a lo mejor algunas personas se
And
van
I
a
might,
incomodar, pero de
some
verdad
people
es
might
cierto.
feel uncomfortable
De
about
que
what I'm
podemos
about to
hacer
say,
prevención de
but it
adicciones
is
y
true that
promoción de la
we
salud
can
desde
do
que incluso bebés están gestando.
prevention and
¿Por
promotion
qué? Si
since the
ayudamos a esa
baby
nueva
is
familia que se está
still
conformando a
in
la prevención de las violencias en estilos de
diapers,
crianza,
essentially.
por
Because
ejemplo,
if we
desarrollar
modify the
que puedan
racing
desarrollar habilidades
styles,
sociales para
the
ese niño o
social
niña que viene,
abilities for the
estamos
kid
haciendo prevención de adicciones
in
y
the
promoción de
family
la salud
environment,
mental.
we are doing
No tenemos que
addiction
esperarnos
prevention and
a que
mental health
nuestros hijos,
promotion. We do
hijas,
not have to
nuestros
wait
alumnos,
till our
alumnas o nuestras
children, our
personas que están
students,
alrededor
or the people
estén
around
en la
us
adolescencia para hablar
go
de
into
este
their
tema.
teenagers to
Podemos
discuss this
abordarlo
matter.
desde
We
mucho
can
antes y
address
desde
it
muchos
from way
enfoques, ¿no?
before
Entonces
and
es
from a different
importante
perspective.
ayudar a
So it
esa
is
transición.
important
Todavía
to
nos
help
falta
in this
bastante,
transition.
pero
We still have a
créanme que
long way
podemos
ahead, but I believe that
seguir trabajando y seguir
we can keep
enseñando.
on working
No es
and
un
keep on
secreto para
pushing.
mí, pues
This
obviamente
is
la
not a
ampliación de los
secret,
servicios de
really.
salud,
The
mayor
enhancement
presupuesto
of
en materia de recursos humanos, ¿no?
health services
En
when
la
it comes to
traducción
human
que vieron ahorita en
resources,
la ponencia anterior
infrastructure, and the
de
translation
accesibilidad,
in terms of
más bien servicios de salud
accessibility
mental,
or
como
mental
recurso
health
comunitario, no
services in
solamente ese
different
hospital
units,
psiquiátrico que está
not
lejos de
only the
2.000 kilómetros, ¿no? Que
psychiatric
implica
hospital
un
that
gasto de
it's so
bolsillo,
far away that
horas de
entails
transporte, el
an
desgaste de la
expense in
familia,
hours
etcétera,
of
¿no?
transportation
Eso implica
and
entonces
essentially a
tenemos
burden for the
una mejor
family.
gestión de los
This
recursos disponibles.
entails also,
Eso también
first things first, a
considera
better use of the
una
available
inversión
resources,
en los
but also the
recursos
consideration of an
disponibles.
enhancement
Obviamente,
in
un
the
presupuesto
resources
destinado,
allocated
¿no?
for this.
Que
Of course, an
el
allocated budget
80% más o menos se nos va
that maybe
en los hospitales
80%
psiquiátricos y que
goes
afortunadamente con
to
los
the
cambios ahora en la
psychiatric
ley de salud
hospitals. And thankfully, after the changes in the
determinaron que ese
general
modelo
health
asignatorio
law with
de los hospitales
changing
psiquiátricos
this
a un
model
modelo
of
más comunitario, ¿no? Sea
psychiatric hospitals to a more
estos
community-based
recursos
one
económicos.
might
Sin
help
embargo,
us to
también
better manage these financial
importante
resources.
señalar
However,
que
it is
el
important to
Departamento
mention
de
that
Salud Mental y
the
de Consumo de
issues when it
Sustancias, el
comes
timing que
to mental
sabemos
health
desde
and
la
substance
pandemia
use is
es
increasing.
que este
When,
problema va a ser
after the
un
pandemic,
motivo de
we learned
discapacidad para el
that this will
2030.
become a
Entonces,
disability in
estamos
2030.
a dos
So
de o lo
we
atendemos
are
o lo atendemos
really
desde la
close to
prevención
the edge
hasta la
of
recuperación, hasta
deciding
la
upon
reinserción,
addressing
¿no?
it all the way
Pero
to reinsertion and prevention.
tenemos que
But
gestionar los recursos necesarios
we
para la
have
disponibilidad de
to
estos, ¿no?
properly manage the
El
resources
enfoque
available for
en salud
this.
mental
The
comunitaria,
mental
como les
health focus,
comentábamos,
it's
requiere
based
también
on
una
community
visión
mental
que
health,
sea
and it
interdisciplinaria
requires also
e
this insight that is
intersectorial, más allá de lo del
cross-disciplinary and
equipito que
cross-sectorial.
tenemos en salud, que de
Besides
repente
these
es el
mental
médico, la
health
enfermera, trabajo
team that's
social,
small, maybe you have social worker,
psicología
nurse,
clínica, y
psychology, and
además
a
otros
doctor.
actores
We
fundamentales
need
en esta
to
materia, ¿no?
broaden our
El
perspective to
fortalecimiento de
other
derechos
elements
humanos.
in this matter. The
Yo
strengthening of
siempre
human
digo, a veces
rights.
somos
I
fuera de la
always say
calle
that sometimes
en la casa, ¿no?
we are behaving and doing much better outside because this human rights matter feels so far away from us that it's just like, oh, well, this person was tied up, or only for the prisons and jails. But when it comes to mental health services, there is a lack of hearing from the basic services that should be providing and the awareness around them. We are preventing them from having their proper rights, civil, economic, and human rights. So we need to better understand from our exercise in whichever activity we carry out the human rights matter and the commitment that we have as public servants. Another relevant point will be the strengthening of strategies for risk reduction and damage. For many of us, this is a complicated perspective as staff because we understand that when it comes to addictions, the only way is abstinence. So we need to look at other alternatives that guarantee a better health in people that decide to continue consuming and other strategies that should be implemented. From the exchange of needles in the northern border, what is more commonly seen with the injected based drug use, to other strategies of damage prevention and reduction. From HIV testing, hepatitis C testing, handing out condoms, hepatitis B vaccination. We should not just focus on abstinence as the only way. It's complicated due to the training that we have as health staff, but we can always keep learning and understanding new perspectives. And last but not least, we have research and monitoring that could provide us a strength to continue along the line that we have been working. That's not exclusive for Mexico. In other forums where we have had exchanges in Latin America or even Europe with these lookout to prevention and addiction care and prevention for mental health and substance abuse. It's not unique to Mexico. However, in other forums, we have seen that our work, the way we are articulating, has seen better results, has seen a better exercise, and has been more impactful than in other places where they're just creating their teams. And well, I would like to thank the invitation. I think I finished on time. Thank you very much.
Gracias, doctora Carmen.
Thank you very much, Dr. Carmen. So we would like to thank you for your participation and your questions. Thank you to the public. We have a question, Dr. Carmen. What are the effective actions carried out from the federal government when it comes to mental health that have had an impact in the well-being of the female population during the pandemic? Wow, that is quite a question. So specifically for females, with the National Center of Gender Equality and Reproductive Health, in this tool that I was mentioning about the program to reduce gaps in neurological addiction and mental health matters, SMH GAP. In this review, we realized that there was a component lacking when it came to violence. I am talking about violence because in Mexico, we're still having this issue where women are still the victims of violence in many aspects, either structural, domestic, labor, and many more. So along this line, along this commitment with the National Center of Gender Equality and Reproductive Health, we developed in 2020 a specific model to address violence and to bring healthcare professionals into this component. I could say, just as I was saying a minute ago, that the healthcare staff have a lack of training in other matters, which is essentially addictions, violence, and mental health, along with many other instances. This component has been what was added to the MH gap. I believe it was added in 2020 and it's still valid nowadays. This has also allowed us to collaborate with other organizations in this matter. Specifically, when talking about direct actions that might have an impact on women in this country during the pandemic, I am not sure I can think of any specifically. However, we have this global one that is actually ongoing. We need to understand that the phenomenon of women that have any sort of mental health or substance use issue have other elements, not only the violence component, but that's what I can think of.
Bien, apreciamos y damos las gracias a
Okay,
la
we really appreciate your time, Dr. Torres Mata, for your valuable input, where you have shown us the different strategies for the addiction prevention, contributing by enriching this Congress on the challenges and successes of mental health. So I would like to give the floor to Dr. Maria Rodriguez to continue with our next activity. Thank you, Dr. Joaquin. We're going to be introducing our moderator for our next roundtable, Strategies to Tackle the Stigma and Discrimination. And I am very honored to introduce Dr. Marcela Velázquez Bolio, who is head of the Human Resources area at IMSS. She has a degree in political sciences by UNAM. She has a master's degree in social policy by the London School of Economical and Political Science. Along her work experience, we understand that she has been centering herself in the support of human rights through the resources of the community monitoring and assessment when it comes to gender, health, human rights, sexual and reproductive rights. She is a founder of the Por Nosotras organization that is focused on the financial empowerment of women. She was a coordinator of the operation of social population and autonomous organs at IMSS, where she created direct conversation and discussion organisms to foster and ease link, articulation, and synergies between the IMSS itself and other autonomous organizations. Welcome, Doctor, and thank you very much for being here. Hello, good morning, everybody. Thank you very much for your invitation. This is a very important forum for us when it comes to mental health. And I would like to start by talking about the objective of this panel, of this roundtable. What are we looking at? What do we want to do? We want to understand the perspective of the panelists that are here with us on how we can fight the stigma and discrimination when it comes to mental health. We would also love to hear their experiences and the strategies that have been successful for them in this regard, as well as the missing points, the gaps. Where should we focus our energy and attention to keep on fighting the stigma and discrimination that comes along these matters of mental health? I will start by introducing Professor Sir Graham Thornycroft. He is a professor of the Community Psychiatry Center at the Global Mental Health and King's College London. He has an honors degree in social and political sciences from Queen's College, University of Cambridge. He is a doctor from the Guy's Hospital, specialized in psychiatry and the Moseley and Johns Hopkins hospitals. He has an MSc in epidemiology at the London School of Hygiene and Tropical Medicine, and he has a PhD at the University of London, focusing on the positive outcomes of discharging long-term psychiatric inpatients to community care. He is a British psychiatry researcher and professor of community psychiatry at the Center for Global Mental Health and Center for Implementation Science at King's College London. He's also a consultant psychiatrist working at community mental health team at the South London and monthly NHS Foundation Trust. He is best known for his work on community mental health services, stigma and discrimination, and global mental health. He has published over 30 books and has written over 670 peer-reviewed scientific papers. Dr. Thornycroft was made a ninth bachelor in the 2017 Queen's Birthday Honors for services to mental health.
Bienvenido a este foro. Muchas gracias por acompañarnos.
Welcome to this forum. Thank you so much for being with us. I think it is important. I have to mention everybody else in the panel. I would like to introduce everybody else on the panel, and then we can start with the professor's presentation. I would like to introduce Dr. Claudia De Canitano. She is a doctor by the San Carlos University in Belize. She has a specialty in psychiatry by the University Skill, and she's a current advisor in Bajo in Washington, D.C. In 1995, she worked with the Ministry of Health in the Cleopatra White Health Center. She has private practice, and she is a consultant and technical advisor of Bajo and the WHO. I'm sorry, we do not have audio. I'm sorry, I believe she has muted herself.
Maestra Marcela, está cerrado su micrófono. Si pudiera abrirlo, por favor.
Could you please open your microphone? So you haven't heard anything? Yes, we kind of introduced, you kind of introduced the first two panelists. I'm sorry, I'm going to continue. I don't know why my microphone muted. Dr. Denny Alvarez de Casa Gonzalez is a surgeon from the UNAM Medicine School. She's a psychiatrist from the Ramon de la Fuerte Muñiz Institute. She has postgraduate studies in applied psychology. She's currently the technical secretariat from the mental health committee in UNAM. She has worked in the clinical area in the treatment to direct and indirect victims to high impact crime and communities exposed to collective violence. She is director of the psychosocial program of two victims of violence. She is also a member of the Human Rights Committee of the National Psychiatry Association. And last but not least, we have Dr. Laura Mora. She is a surgeon from the Instituto Tecnológico de Santo Domingo. She's a specialist in primary health care, and she's an epidemiologist. She has a master's in social security by the Alcalá University. She's currently the health director from the Psychiatry Council in Dominican Republic. She is a director in charge of the promotion of the contributive regime. She's in charge of special programs where she was part of important programs like Senasa Contigo and Senasa Cuida de Ti as part of coverage policies to the general population. She works in the health area of Santo Domingo, in the west side of Santo Domingo, and she is part of the coordinating network of mental health. She is also in charge of the COVID. She was also in charge of the COVID network. She was also in charge and participating in the protocols for COVID. So let's start our roundtable with a presentation of Professor Sir Graham Thornycroft. So the floor is yours.
Thank you, Marcella. Would you like me to begin? Okay. And first of all,
please.
Marcella, please tell me if you can see my slide.
Yes, Professor, we can see it.
Okay. And can you see it full screen now?
Yes.
Se ve perfectamente.
Yes.
Okay, very good. So thank you very much for your very kind introduction, Marcella. And thank you for inviting me to this meeting. I'm sorry my Spanish is so bad. I will give a talk in English. And I bring you greetings from a winter's day on London, which is cold and wet and windy. My topic today is about stigma and discrimination, specifically on how we can reduce and stop stigma and discrimination, and what evidence do we have. I'd like you only to remember 2 words from this talk. And these are those 2 words: social contact. The words to remember are social contact, social contact.
Las palabras a recordar son contacto social, contacto social, contacto social. Ahora déjenme decirles qué es lo que pienso.
So I'm talking about stigma. In my country, this is one example. Behind, you can see a home for old people, and there was a proposal to change this to a home for people with mental health conditions. And local people were not happy. They protested, they had signs like this, they went to the town hall, they were against the plan. So this is an example of stigma that I'm talking about. But this is not only a topic for me of academic interest. This is my mother. She is now 94 years old. And when I was 3 years old, and she was working then as a nurse, she developed a period of severe depression. In fact, she was suicidal then. She had various drugs which did not help her, but she did have electroconvulsive therapy, and she fully recovered. She went back to work, and she did not tell her boss why she had been away from work. She said she would have lost her job if she had been open about her mental health condition. And we did a chapter together about her experiences. And she said at the end of the chapter, "I hope that people are more understanding these days." So many years later, I developed my research interest in stigma. And I wrote this book. And as I researched everything I could find about stigma, my focus changed from stigma to discrimination. So I want to give you some examples first about large-scale anti-stigma programs in high-income countries. And in the last 20 years, there have been about 12, maybe 14 national or large-scale programs you can see here. Perhaps the earliest was in New Zealand, and then Scotland, and then Australia. Some of these programs have evaluated their impact. I'll give you one example, which is the program in my country, in England, a program called Time to Change. At the bottom, you can see 2 large non-governmental organizations called Mind and Rethink were running the program, were delivering the interventions. And my university, King's College London, evaluated the impact. I'll give you a few examples of the impact. Every year, we carried out a large-scale public opinion survey over 12 years. And we found approximately a 10% reduction in stigma among the whole population. We also asked about people's behavior intentions. Would you like to live with a person with a mental condition, to work with, to live near, to have a relationship? And you can see we had a range of between 5 to 10 to 15% reduction in behavioral intentions. But even more important is real behavior. So every year we telephoned 1,000 people across England, 1,000 people with severe mental health conditions, people receiving treatment. And we said to them, what is your experience of discrimination in the last year? And again, we found reductions of 5 to 10 to 15% across the whole program. So we were able to show important, modest, but important reductions in stigma. We were able to prove that it's wrong when people say you cannot reduce stigma. And we were able to show that it takes a long-term commitment to reduce this type of discrimination. In the last 10 years or so, we've also seen increasing evidence from low and from middle income countries such as Mexico. And to summarize a lot of this evidence, social contact appears to be as effective in low and middle income countries as it is in high income countries. It is not correct to take a program or an intervention from one country and to export it or to transplant it to another country. The principle of social contact needs to be applied in a way that is culturally and contextually adapted and appropriate, and which is simple and cheap enough to do. And we need more research from middle and from low income countries about practical ways to deliver stigma reduction. And we've seen evidence, particularly from anti-stigma programs with young people, for example, in India, that when it's designed or co-designed with the target audience, for example, with young people, then they can have very interesting, sometimes fun interventions, games, magic shows, puppet theatres, and so on. In the second part of my talk, I want to summarize a recent detailed report on how to stop stigma. This is called the Lancet Commission on Ending Stigma and Discrimination in Mental Health. And I led this jointly with my colleague Charlene Zunkel, who is based in South Africa. And she is the founder and the chief executive of the Global Mental Health Peer Network. The whole report has been translated into Spanish and is available at the Lancet website. You can simply type in English or Spanish, Lancet Commission on Ending Stigma and Discrimination in Mental Health, and this is available to you. What did this report aim to do? First, we wanted to define stigma and discrimination. Then, to look what the impacts of stigma are. To understand the evidence of effective stigma reduction interventions. To assess whether these can be delivered in large-scale programs and what experience have we accumulated. To understand how the media can help or can harm stigma, and then to make specific recommendations. This was the work of many people. Those directly involved we called commissioners, about 25 people from across the world, but also about 25 advisors, again from many countries, most of the contributors from low and from middle income countries. We decided to put the voice of people with mental health conditions in the center of this report. And so there are many poems and quotations included in the Commission report. First, how to define stigma. Having looked at all the literature, we came up with this suggested structure. The first type is self-stigma, sometimes called internalized stigma. The second is stigma mostly which affects family members, which is called stigma by association. Sometimes it's called affiliate stigma or even courtesy stigma. And this can also affect people working in the mental health field. The third type is called public stigma, and here we saw three different component parts related to misinformation, prejudice, and behavior. Where there is a lack of sufficient or clear or correct knowledge, we call this misinformation. Where there are negative attitudes among the public towards people with mental health conditions, we call this prejudice. And where there are behaviors which are socially excluding, we call this discrimination. The fourth type of stigma has been less well defined and less well studied, namely structural discrimination, sometimes called systemic stigma or discrimination. For example, when countries have laws which, for no good reason, exclude people with a mental illness, for example, from owning property or marrying or carrying out a legal contract. For example, at the large scale, the miserable amount of money spent by most countries on mental health care and mental health services can be seen as a manifestation of structural discrimination. I'll just say a little bit about the impacts of stigma. As you work in the mental health field, this will be familiar to you. In many countries, basic human rights are contravened. For example, in about 20 countries in the world, suicide and self-harm is against the law. There are many forms of social exclusion, for example, in education and in the workplace. Often, the amount of mental health care available is very limited, and people who have mental conditions receive worse physical health care, which contributes to earlier death. So for our report, we commissioned a special survey of people with lived experience. This phrase in English means people who have mental health conditions now, or people who have had experience in the past of mental conditions. About 400 people took part from many countries, and the survey was carried out in the 6 global languages recognized by the World Health Organization. Most of the participants did not come from high-income countries. Here are some of the main results. That people with lived experience, people with mental health conditions, should be treated as well as people with physical conditions. The stigma and discrimination negatively affect most people with mental health conditions. Government should pay more. The media can make stigma and discrimination worse. But the finding that most troubles me, most bothers me, is this one. Stigma and discrimination can be worse than the impact of the mental health condition itself. People here with often severe forms of mental health difficulty, and even so, 80% of respondents from over 40 countries around the world said stigma and discrimination can be worse than the impact of the mental health condition itself. We also looked at the evidence of how to reduce stigma. We looked especially for systematic reviews of stigma reduction, and we found over 200 systematic reviews. We then synthesized all this information. The technique is called an umbrella review. And the clear finding is that social contact is the most effective intervention to reduce stigma. What does this mean? These are the 2 words I'd like you to remember. Social contact means direct or indirect contact between people who do and people who do not have experience of mental health conditions. For example, direct contact could be 2 people with experience of a mental health condition standing up in a classroom teaching young people, or a group of people training to be policemen, or a group of medical students or nursing students, or any other group. Indirect social contact means online or remote or digital contact. It could be a short film, it could be a webinar, it could be a blog. And interestingly, in the last few years, there is increasing evidence that indirect social contact can be as effective as direct social contact. We looked at large-scale programs you can see here in different parts of the world, and we actually included with the report an appendix, about 100 pages, giving a lot of detail about these programs, how they started, how they continued, how they were funded, their successes, their failures, what they've learnt. So there's a lot of very practical information within this Lancet report. The roles of the media I can summarize briefly. They can be powerfully negative or positive. Media can be negative if they reinforce stereotypes, for example, of unpredictability or dangerousness. Media can be positive where they, for example, follow guidelines on responsible reporting, for example, on suicide. But there's no doubt the roles of the media, the traditional press, the traditional broadcast media, and the new and social media are extremely important in relation to stigma. We found in many countries many miserable and negative words used to refer to people with mental health problems. You can see in English some words here. I expect in Spanish you will have equivalent negative terms and words. And we came to the view that better is to use the person first approach. So we might say, for example, a person with diabetes or a person with HIV or AIDS or SIDA. But in this case, we would suggest using a person with depression or a person with lived experience of anxiety. And this will also be very often culturally appropriate. If in doubt about which words to use, ask people with conditions about which are words experienced as respectful when referring to a person with an experience of a mental health condition. We finished the report with a call to action. Mental health is part of being human. Let's act now to stop stigma and to start inclusion. And we provided 8 specific recommendations, one of which, for example, is to produce a stigma toolkit. And now we're working with the World Health Organization to produce a short, practical, simple, clear guide about how to do anti-stigma actions, and that will be published next year. So just as I finish, I'd like you to remember these 2 words. Social contact is the strongest method, evidence-based, to reduce stigma and discrimination. And this has an important implication. People with lived experience are the key active change agents to reduce mental health stigma and discrimination via, that means using, social contact. So in closing, I want to mention that about every 2 years is a global conference about stigma. And this was a couple of years ago in Denmark. And these letters are about 1 meter high. And you can just see perhaps at the bottom cables, which are very low grade heaters. And that meant over 2 or 3 days of the conference, the ice, the stigma slowly faded away. And that's what I want to see through our efforts worldwide to get rid of the unfair and the wrong forms of stigma and discrimination that are so common today. If you'd like any more information about this topic, please do contact me and I can send you more details. So in concluding my work, I think perhaps I pass back to you, Marcela, and let me thank again the organizers for inviting me to join you today. Thank you.
Muchas gracias, profesor. Qué maravillosa ponencia, de verdad.
Thank you very much, Professor. It was a splendid presentation. I know that you have limited time, so before moving to the next presentations, I would like to take this advantage because we have you here to ask you a couple of things about social contact, about what you were talking about social contact. What happens or what would happen if the social contact between people having these prejudices and the people with some mental condition may result in more isolation. May it affect the contact, the social contact? That is the first question, Professor.
Is that a question for me, please?
Yes,
Okay.
Professor.
Okay, thank you. So I've only
Yes.
just found the interpretation button at the bottom. So a note to the interpreter. Could you briefly summarize the question again, please? Could you repeat the question, please?
What if social contact is between someone who is prejudiced and a person with a mental condition, and then couldn't it cause more social isolation in that way? And if we talk about groups, what will happen then?
Okay, so now let me add a little more detail about the types of social contact and how it can be delivered. So social contact can be a risk if you say too much to the wrong person who may be prejudiced or discriminatory. And that's, of course, the nature of stigmatization. So often people will want to join a peer support group or a patients group to gain confidence, but also to practice how they would like to prepare and deliver their story or their narrative. And it usually will be more helpful for 2 or maybe 3 people to go to a session to explain their point of view and to give each other support. People organizing an anti-stigma session will usually want to have a preparation for the speakers, a moderation during the session so that you don't allow negative comments to be made, and then debriefing and support for the speakers after the session as well, and any key learning points. But there may also be situations in which people would like to contribute to an anti-stigma session, but not to disclose their own experience or their own diagnosis. Now, there are ways to do that. For example, you could organize the session but not speak, or you could put on a dramatic play, a story, in which you have actors playing the part of a person with a condition and a family member. And the actors, of course, may or may not have their own experience of the condition, but they're playing the role in the story. And then sometimes in the discussion after the play or the drama, they might disclose their own experience or not, but it's open to them. It's a flexible situation. In some situations for children, you can use puppets, or you can use caricatures or cartoons or other ways where the storyline is clear, but it does not require a person with a condition to make a potentially risky disclosure, which they might later regret. And another way is to use what we call conditional disclosure. And this means, let's say a young man meets a young woman. The young man perhaps has depression. He doesn't know if the young woman is going to be sympathetic or not. So he might initially say, in the course of a drink or a meal, look at this story in the newspaper. They say, loco, this is terrible, and see what the other person says. And if she says, well, I know a lot of people with mental health problems, it's very common, you shouldn't believe everything you see in the newspaper, then maybe at the next meeting say a little bit more, saying, well, perhaps sometimes I get a little bit down. But if she says there are a lot of mad people out there, you've got to be careful, the streets are dangerous, then maybe he doesn't say more. In fact, maybe she's not the woman for him.
Sí, probablemente, ¿no?
Yes, probably not. And the last question, Professor.
You were talking about the media, the role of the media in sometimes being prejudiced or discriminating against people with a mental condition. So can we actually work with the media in this? Because media, for example, in Mexico, also in the UK, is really plural, and there's this thing between how do we educate the media on this, and how do we get the media to contribute to ending stigma and discrimination?
So thank you. So I think the first thing to understand is that people working in the media are often working in very stressful conditions. They have deadlines all the time. And there's very little written about how common mental illness is among journalists, except for people in war zones and post-traumatic stress disorder, or except for alcohol-related conditions. But I would say that probably mental health conditions are at least as common in journalists as in the general population, probably more common. So this is not a strange concept. Now, I think there's two approaches. One is to punish journalists. So a consumer group might set up a watch system. Every time there's a mad murderer story, they send messages to the broadcasting station or the television and so on. And you try to sort of shame them from doing more. Maybe this helps a bit. I think a more positive approach is to deliberately reward good practice. So, for example, every year in my country is a national mental health media awards evening. And there are maybe 10 or 15 categories of best television show, radio show, journalist, young journalist, local newspaper, daytime chat, television, telenovela, and so on. And then people submit their programs, and then it's like the Oscars. And then the three best people walk on the stage, and there's a celebrity saying, and the winner is, and they open the envelope and so. And year by year, this has got bigger and been more prestigious. And people really like being rewarded, having prizes, having recognition. So that can change the culture so that people actively want to be doing and to be seen to be doing good practice in media reporting. And I think that's made a big difference in my country.
Thank you very much, Professor. Voy a resumir en español. Sé que
I am going to summarize in Spanish. I know that the professor has to go. First, I'm going to summarize my intervention. Thank you very much. Let's talk more about the social contact. It's a great concept. We are going to buy that book, Professor. And we are very pleased at the Social Security, the IMSS, because we are working a lot with reinforcing this positive thinking beyond punishment, but to do recognition. So we can strengthen that here, but we can also tell the media, because this is a great project. Thank you very much, Professor. Thank you very much for your participation, for being with us today. We would like to have you more time. We are going to invite you more often if you allow us to do so.
Thank you very much. Gracias a todos. Ciao. Adiós.
Profesor, gracias.
Thank you very much, Doctor. This was a great participation of the professor. Now we continue with Claudia Cayetano. Doctor, be you welcome. Thank you very much for accompanying us. We would like to hear your participation and to encourage with the rest of the participants. I think that right now, because I'm going to be changing the dynamic, and Dr. Claudina and Dr. Denim presentations, let's hear them three, and then we will start talking about the topics. Dr. Claudine, be you welcome. I am very glad to be with you. The truth is that
tipo de conferencias, de congresos. Entonces voy a empezar compartiendo la pantalla y creo que, Marcela, me cuentas cómo la están viendo.
Marcela, please tell me how are you taking a look at it, if you're seeing it.
A ver si la puedo poner para... Ok. Y la
Hopefully I can
quede esto
share it
otro lado.
differently.
Hoy sí. Ahí
Ya.
está.
Okay.
Doctora, sí, ya. Gracias.
Vamos, perfecto.
Okay,
Bien.
thank you, doctor.
Mira, pues
So
ya me presentaron.
I was already introduced.
Un poco de diferencia cuando hablaste de la Universidad de San
It's a
Carlos
little
en
different
Guatemala,
from when you were
sí,
talking
sí,
about the San Carlos
sí,
University in
sí,
Guatemala.
Magil, tal vez solamente para aclarar
Maybe
esa parte y que
just to
trabajamos
clarify
con
this
la
part, and then
Organización
I'm currently
Panamericana
working with the
de la Salud como
Pan American Health
organización regional de
Organization,
salud mental
PAHO, as
actualmente
a
estoy
regional
en
advisor of mental
Washington.
health, and I am
Bien,
currently in Washington.
este es un tema que
So
definitivamente me
this
encanta
is
y tengo
a
por ganas
subject that
de
I'm very
hacer.
passionate about,
Hicimos
and
una campaña.
we
Incluso
did a
estoy
campaign,
impulsando
as you
esta
know.
campaña
I'm
para que
actually
sea mi
looking at
background,
these
¿no?
campaigns, so
Muchas
it's my
gracias por la
background.
invitación
So
para
thank you very much
participar y
for
hablar
the
un poco sobre estas
invitation to
estrategias
participate
y
and
estos
talk a
son
little bit
temas que
about the
debemos
strategies, and these are the
conversar.
subjects that we will be
Entonces,
discussing.
me gustó muchísimo.
I really enjoyed
Tuve la oportunidad de escuchar
the
primero
opportunity
Tony
of
Ultramagil
hearing
porque todo lo que han
Professor
hecho,
Tony Graham first,
aprendemos por repetición.
because of course we
Entonces,
learn by
por momentos
repetition, right?
opiniones
So there will be times where
me refiero a algunos conceptos
I
que él mencionó.
also
Y me parece
work on
muy
some concepts that he
importante
mentioned.
con esta pregunta, el por qué
And
estamos
I think
preocupados
we
por el
should
estigma.
start with
Y él
this.
presentaba que era
And when
importante
it comes
cuando
to
hablamos
why do
de
we have to
un
be
edificio
concerned about this
y yo
situation? He
presento
was talking
acá
about this building, and I showing
esta es una de las
this
grandes
fence.
barreras,
This is
no
one of
debe
the
ser
biggest
una,
fences,
y
right?
es
Like a
muy
barrier,
importante que se
that
debe
it's very
elaborar, porque
important.
esto es lo que
And
parece
this has to
nosotros
be
queremos
tackled because this is
reducir
what
la
we're
brecha
looking at
del
reduction,
servicio
is
de salud.
gaps of mental health services.
Es lo que debemos de ir luchando,
This
cómo combatir el estigma, ¿no? Creo que es súper importante
is what
hacer
we
esto.
need to fight the stigma.
Si nosotros nos podemos
So
a imaginar a una persona
when we
con una
think about a
fractura de
person
pierna
with
y
a
la
fractured
persona
leg,
tiene esa fractura,
and the person that has
esto
this
le afecta
fracture, of
caminar.
course, this is affecting
Esto
in
le
their
afecta
walking.
movilizarse.
This affects in their
Entonces,
movements.
los amigos o
So
sus
their
familiares
friends or his family
no van a pensar que lo hace por llamar la atención.
won't think that this is just
No
to
van a
cut
pensar que la
people's
persona
eyes.
lo
They
hace
won't think that this person is doing it because they feel like,
no van a
or they have
pensar que
there's
la
a
persona
problem with their
tampoco
personality. And a person won't think,
no
find it hard to admit that they have an issue.
Pero se dan cuenta la diferencia cuando
But
tenemos
do you
un
realize
problema
the
físico
difference
a tener
from
si
a
esto lo
physical problem if we compare it to a person that might be depressed? A person that might be depressed, probably the family, their friends will think that they're doing this just to catch attention. Maybe they have a problem that they don't know how to solve it. They have an issue, a personal issue, and it would even be hard for them to say, okay, I am depressed. And even the person wouldn't really look for treatment because they know what it entails to talk about this. So these are very clear issues when we talk about those barriers for the demand. It's very often where people find it complicated to look for help. Why does this happen? There are several reasons, not only the stigma, we know that. This slide, what I have right here, it's extracted from the latest world report by the WHO. And they said that these barriers, these obstacles, when it comes to health services, they might be not easy to access, they might be too expensive, but mainly it was about the quality. And it's also the lack of education on mental health, the lack of understanding. And this is where we would also have the beliefs and attitudes, the perception that people have because they have this lack of awareness. This is where the stigma comes from. These are perspectives from and stereotypes. So the fear and the embarrassment that people feel discriminated, the violation to the human rights also occur in this stage. But the key is that the stigma, when we talk about stigma, we should also mention the importance of discrimination, because this is exactly where it leads. It's discrimination and exclusion. And we know that a good percentage of the treatments in low-income countries are not the required quality. So these complicates even further the barriers of demand. I think we have talked about the origins and social origins of the stigma, but maybe the relevant part here would be to highlight that there is this difference, and there is a real difference between the disability and the disease, and how we start to create these stereotypes, the relevance of this, and the prejudice. How do we think or create this division of them and us the normal ones and them with an issue? But it is a mental health issue. It's a physical, if it's a physical problem, we don't do the same thing. And discrimination doesn't really occur the same way, either directly or indirectly. But it's not the same when it comes to a physical problem. So what do we know? What do we know about the stigma in disease in Latin America? I believe that the previous presentation talked about some research, but I believe it's always worthy to mention some here. I do mention a professor that sent us this information, where it's essentially a search in a database. This is something that we have been working on in the Complutense University. They carried out this search, and when they searched for disease, they found 181 posts. When they type in disease plus country, we can see a few more, 2,488 in several countries, not only their country. But that is the issue. There's such minimal information that if we compare it to other countries, when we try to find out what's happening, for instance, when it comes to mental health and disease in other countries, we realize that, for instance, the UK, where the professor is from, maybe 8,000 posts would pop up. That's one of the largest differences that we have between the countries that invest in posts, in understanding, in knowledge, information, understanding what is happening. And as you can tell, we have Australia in second place, then Canada, and then Spain. This is what we see when we talk about communication. But we know that this is something that's being worked on. It's not that we are far behind. If we talk about the reform of psychiatric care, if we talk about the Caracas statement that happened a few years ago, we have seen this slow increase that is also relevant. We want to see more. We want to see a little more because we know what to do, we know what can be done. And amongst the main publications that we can find on this matter, you know that there's Brazil, King's College, London. That's why I believe they invited them to present Colombia, Mexico, and Chile as well. But we'd like to see more. We know that that a lot has been done when it comes to information spread. And also about the research that has been done. This is a study on the stigma of mental health disease done by Toledo, Mascayano, on the stigma and the mental health disease in Latin America and the Caribbean, where we can see more studies. We're looking at almost 40 studies, papers that address these subject in different categories across Latin America and the Caribbean. So we are investing, but it is a slow investment. I won't stop too long here because I believe we have already discussed these main matters that become so relevant to bear in mind. What are those three levels of stigma? When we talk about the levels of stigma, I believe that Professor showed a very interesting slide on individual, professional, and structural stigma, and all of those kind of prejudice when we talk about the different types of stigma, and what can be done to improve mental health and access to mental health to reduce the stigma itself. So this was the paper that was mentioned. It's the one from the Lancet Commission. That was the one that was released in 2022. And it was already discussed, and I loved it because, as I said before, we learn by repetition. So it is important. We know that there is a publication already, and we know what to do. There are interventions, but we are still having issues. So among the strategies that are mentioned, protests that are important, the fact that people find education and awareness. Some people like writing about their experience, the advocacy, the importance of reforming the laws, legislations, and we talk about the personal responsibility. But what he mentioned that I believe it's very important is that all of these strategies that we know have been worked on, the social contact strategy is the most important one. Why is it important? Why are we talking about the importance of this recovery and the opportunity for this person to get hope, to be part of a team? So we are not looking at this person like them and us, but the social contact, how people could have a psychotic break, but they can also have a normal life. They can also have a social contact where they're not discriminated because they were diagnosed with a mental health disease. So I think this is key, and I really enjoyed that that was the previous presentation. And this is where we emphasize again the importance of the social contact. It is very important when we're doing this sort of research and we have this sort of interventions to understand what are these key focal groups that are mentioned. There are several ones, but if we talk about the youth, we have had research done on the importance of having groups to address. For instance, the youth, this is the importance where we can still tackle their perspective and their perspective on life. So they're a little malleable. That is the importance, but it's not the same to deal with an older person or even an elder than doing it with a young person, since we already have the opportunity to address these concepts. So we also mentioned the relevance of working with the media and of course healthcare professionals. And this is something that is very relevant because you would say, okay, healthcare professionals, when you have a health issue, you go to them and you would think that they are trained because they are committed to do their best. However, there are many research around, there is a lot of research on the fact that healthcare professionals might have the worst attitudes when it comes to discrimination. We have been working with the Mental Health Commission of Canada, with whom we have been doing a lot of research on this matter. So we have collaboration centers in collaboration with different entities, and the collaboration with the commission, with the Canada Mental Health Commission, they have been working on different studies, and these research include some interventions on working with mental health professionals and healthcare professionals. Why? Because we have these attitudes that have been obvious when it comes to these trends towards hostility, blaming people for their issues, blaming them and saying that that's their issue, making it a personal issue. And sometimes what we find is that they think that people won't be able to leave this issue. And this is what we see when we talk to healthcare professionals. So it comes with the importance. Sometimes they don't realize that they have these stigma-based behaviors, or that they are manifesting this stigma-based behaviors. And what happens to patients? The patients feel that having this disease is annoying, that having this issue, it's humiliating, and we have this overcompensating attitude. I remember this patient that we had that said, look, doctor, I have this disease that was diagnosed with schizophrenia, and their family, his dad also had schizophrenia. So he said, "This is something that I didn't ask. I didn't woke up this morning and said, this is what I want to have." This is an issue that they sometimes know that based on this issue, they will have a lesser quality care. And they're essentially are being blamed for this. So I believe this is key when we're talking about mental health patients. They sometimes face this issue, and the fact that healthcare professionals could foster this unless they're educated on the matter. So when we're talking about addressing the roots of the stigma, this goes along with the commission, and they realize that healthcare professionals need to be trained because sometimes they don't feel at their best, they don't feel comfortable, they don't feel like they have the abilities or the trust to address these kind of issues. And I'm pretty sure that you that are connected sometimes feel that when we are in this hospital environment or this community environment or health environment, there are colleagues that say, well, you know what, I'm not into mental health. I do not like working with mental health patients. I just don't like it. I'd rather work in something different. So that's where you realize that between us, we also have this stigma on our shoulders. It might be a matter of lack of awareness and prejudice. And just like Professor said, we are looking at the disease before the person. We see the disease. I love what he said. This is my mother's. That's his mother, not the disease. So that's what we normally see. We talk about the person and we don't talk about the schizophrenic or the bipolar person instead of talking about the person themselves. So these sort of things are important to address. When we talk about the programs for the reduction of stigma and discrimination, it is key, and this is mentioned again. It is important to include social contact. For us in Tahoe, we have been aware that many of our activities, we try to invite people with experience, life experience. It's not the same to have a doctor talking about an experience rather than someone who went through a depression, someone that has lived with bipolar disorder or schizophrenia. So this is key first and foremost. And then in the story has to be a story that's useful, that brings hope, that helps the mental health providers to understand what they did right, what they didn't do, and how their behavior helped this person. What did they do to make this person feel better? I'm gonna speed up a little bit because I know we have other presentations, but these programs should focus on the change of behavior, what should be said, how you should say it. And it's important to break the myths and emphasizing the recovery that the programs should be uh, clear in terms of social contact. This person should be the one that needs this support. So this would help in the reduction of everything around stigma because we would be promoting professional relationships that are useful, that inspire trust, and the healthcare professionals would also find it useful to understand how to behave with someone with a mental health crisis. This is very important. Just like somebody that has a fracture has a crisis, just as a person that has a mental health crisis, and the behavior of this medical staff has a very large impact on this. So, what has the PAHO done on this? There are several strategies. We have done trainings. We have a virtual field that is accessible. We have done trainings that comes with mentorships. We have a self-training mentorship. I would leave this here, but this is back when we started advertising it. These are free. trainings that are there. And we also carried out a campaign that is the Do Your Part. The Do Your Part so we can support mental health. This was launched last year for the Day of Mental Health. And we have social workers involved, many young people, a lot of countries helped us to do their part to improve mental health. Now I would like to show you this QR code. So you see some of the resources that we have of the existing trainings that are free, self-taught. I would like to invite you to take them. Especially the stigma one. I think this is very important, but there's others that we have recently released. So we have the reference here for this presentation, and I would like to wrap up by talking about the campaign Do Your Part. This is still available in the PAHO website. So thank you very much for the opportunity. And I would like to leave the floor to Dr. Marcela again. Thank you very much, Doctor. This was amazing. This is just spectacular. I think we can, let's go to Dr. Denny's presentation. I took several notes, but I think it's important that we keep discussing the social contact part. I want to read every book. Dr. Debbie, welcome. Welcome to this forum. You're muted. Technical coordinator in mental health.
Technical coordinator. Dr. David, you are already sharing your presentation. It's going to be very brief. I don't want to repeat whatever was already mentioned so that we have more time for the discussion. I'm going to talk about an experience that we had when we designed a strategy about collective violence. First, I want to make a reference about where are we standing in Mexico. In Mexico, we are subscribed to the people with disability, and based on that, we are going to see some other changes that we had to make a better enforcement to take care of their independence, autonomy, and avoiding discrimination actions. Recently, in the 2022, we performed this conference about addictions, determining that the services should be performed at community level. It doesn't mean that it is going to be disappearing at other level, but we are trying to migrate the specialized services, not only in the hospitals for mental health issues, but to the community, and to provide this service as the general services. Mexico has been in this transition to implement a series of mechanisms that will allow that people with these kind of issues have access to the services in the community. And there are some changes to facilitate this service. However, we have mentioned some rules so that people can have access to the services if they are not available at the community services. But we also have to see the stigma self-esteem. This is the result of a systematic review of 22 studies where we saw the limiting factors and making people not asking for help. However, we have some others, for example, access difficulties, time, distance, knowledge, symptoms, and lack of knowledge about the illness or the availability of the mental health services. There are other special things which are specific for certain groups of age. For example, for teenagers, it depends on the parents approving that the adolescent visit a specialist, and in the elderly people, some limitations to move to see a specialist on mental health issues and some behaviors that have been described regarding looking for help. For example, the gender differences, because sometimes it is mostly associated to females. Also, the double stigma, the people that has gender violence, and they also have a mental health issue. Here we can also talk about the stigmas. Also, to recognize the gender differences issues with the main stressful factors and the main determinants, so that a person with some of these conditions provided details. The researchers made by the health institutions are showing that the trauma events may result in depression. They have to trust that they will get rid of those events and not incur into suicidal behaviors. Sometimes with this violence, we have twice the probability of developing complications after birth. Regarding psychosocial services on the gender violence, and this is not happening only in our country, because only 40% of the women with violence from the partners will look for some type of support. In Mexico, we know that we have a lack of denunciation about sexual crimes. A survey made to women looking for these health services showed that only 2.4 were referred to specialized units to violence services. Really, the number of people affected by these issues do not go to see a doctor that may help, and the barriers and limitations faced by the victims of sexual violence and access to psychosocial attention. It is the fear to be rejected by the society. Sometimes the people is blamed or is minimized. They have a lack of trained people and also the things said by the aggressor. Also, the stigma perceived by victims of violence. We have seen that when women that are victims are stigmatized, and they have a higher probability of sexual violence, and that depressive symptoms in depth are more intense in violence from their partner, because they are referred as a negative social attitude. It is important to have a joint participation to see this mental health in a jointly way, and it should be implemented. For example, to have some services to take care of victims of violence and to take care of mental health. In this context, we have a very wide program in a community of Guerrero implemented due to social violence and also the violence made by the organized crime. We were interested in knowing if we could implement some kind of intervention addressed to women regarding the first level services, taking care of mental health and stigma, and also to find some help. We work on these 6 topics in participative workshops: the violence in our lives, the human rights of women, local mental health access, taking care of our mental health, design and promotion of mental health for women, socialization and proposals and evaluations by the women in the community. Here we had some groups from Prospera that were invited to participate, and we formed 5 groups with 15 to 20 participants. A survey was used before starting the workshop about using these mental health services if they have some kind of issue, and also to reduce stigma regarding mental health issues. what we found, it was that there was a big difference, a significant difference with a significance of 0.053, and it has been decreasing this propension not to use the mental health services, but we still more ongoing work. These were some of the changes that we found. If they are depressed, they have to go and see a psychologist, and 90% said that they would go, and it was increased 90 to 96% at the end of the participation. Sorry, there was an overlapping voice. In conclusion, we can say that the people affected by sexual violence and gender violence are having complications and double stigma. The access to psychosocial support services limited.
Maestro José Antonio Alcocer, si pueden apagar su micrófono. Muchas gracias. Continúe, doctora Deni, por favor.
It is important to make strategies or strategic interventions address to special populations and to work at the first level with interventions integrating both components in a way that we may favor that those women, and essentially it is important also to talk about men suffering sexual violence, because they must have access to psychosocial services and accept the help, because a self-stigma is one of the main indications to approach these services. And that's all for my part. Thank you. Thank you very much, doctor. It is extremely important to talk about intersectionality and the gender component and how it is affecting much more women, mostly by stigma regarding violence affecting mental health. We are going to retake this. It is really very interesting. Now we have the last presentation for today with Dr. Laura Maciel Laura, Director of the Social Security in Dominican Republic. Dr. Laura, be you welcome. How are you? Hello, my greetings. How are you? Thank you very much. Be you welcome. We hear you. I'm going to share my screen.
Ya, nada más hay que ponerla en grandota y ya está.
Sí, un momentito. ¿La pueden ver ahí?
Can you see it there?
Sí, sí la vemos.
Yes, we can see it.
Se ve como pantalla completa.
But we cannot see it as full screen.
Voy a dejar de compartir aquí un momentito. Ok. Y ahora.
Can you see it now?
Doctora, creo que ya lo estamos.
Yes, we do.
Ya, doctora.
Excelente.
Okay, excellent. First of all, good afternoon. To thank for the space. Greetings from the National Congress on Social Security from the Dominican Republic to talk about the mental health in the Dominican Republic. It's a topic that we say with something that a lot of concern, because I know that there is a historical depth regarding our country, a country that after the census on this year, we have about 11 million Dominicans. Our mental health, although it has always been in the paper and it is visible, and we have always had this duty of making it clear, we understand that we still have a lot of challenges. With no further preamble, how to fight this stigma and discrimination in our country, we needed to make a summary of the legal framework. What was the path that we followed since the beginning of this protection of warranties at national level. So we start first by saying that we have a robust law, SEMAR, brought in our Magna Charter we have regarding sensibility. In the fourth chapter, they talk about the warranty coverage on mental health attention and including the part of the rehabilitation of mental health. Now we are talking about 2001 when we started to this revolution on social issues. It was to ensure the access and that every person diagnosed associated to mental health may have the opportunity for rehabilitation. At the same time, in the 2001, we have a social law saying that we have with three lots because each country has its own reality and taking care of the reality, how can we see the approach or the scope on everything suggested? And also we included the protection of health, not only the physical health, but the mental health, talking about the importance of visibilizing and to make known the actions to counteract the statistics on mental health. We also have in the national strategy a whole range of actions addressed toward treating and rehabilitation on mental health issues. On 2006, we already had a mental health law stating not only rights and duties, not only to ensure access, but also to protect against stigma and discrimination. However, we have been focused, and you can see in item 6, in enlarging the coverage and access, putting aside and being responsible to listen everything that has been done in the past. And this is like feedback and like motivation to promote that integrally we can visibilize the part of protection and stigma. Within the prevalence, when we talk about the mental health issues, the Dominican Republic shows some figures that not encouraging. Mostly after COVID, we say that 90% of the population have a mental health issue. And within the prevalence of these mental health disorders, we estimate that 4.7% of the population has a mental health disorder. The most frequent is anxiety, 5.7%, and within the life phases of the population, we can say that from 15 to 49 years, mental disorders have the 1/4 of the illnesses in men and women. So anxiety and the use of drugs that are being included in the statistics. At the same group, we can say that in this population, 15 to 49, the behavior and the illnesses load have a 5.3%.
Doctora Tania, si pudiera apagar su micrófono, muchas gracias. Continúe, doctora Laura, por favor. Tiene apagado su micrófono, doctora.
Sí, ya.
Listo, muchas gracias.
Así también hablando en referencia de los
Talking about the age groups in children and adolescents, in the 5 to 14 years old, they say that the mental disorders represent 10% of the years of life adjusted by disability abad. Besides the suicidal behaviors, it was shown that to the 2018-2022, the suicidal national rate increased 32%. Now we have 5 suicides per every 1,000 inhabitants. This was after the COVID pandemic. Also, the consumption of alcohol, one of the reasons, with several reasons, leading the population to this disorder is that we have a rate between 21 and 9.1%, 9.1 in females and 21% in males regarding these mental health disorders. Regarding the stigma and discrimination, we have a law that is currently being reviewed. It is in the legislation planning where many experts are checking, adding, generating contributions. However, the important topics identified in order to include all the topic to face stigma and stigmatization in our country is to promote the protection of human rights, because besides having access to mental health services, and now I'm going to show you how the access is formed regarding the provision of these services. The community approach, we moved from reaction when a person is identified with a mental health disorder, they receive aid, and if the family did not have resources, then the person was allocated to a health space, ensuring not only the provision of the service but also care. Obviously, they were isolated from family, from the community, and no rehabilitation was ensured. And besides that, based on what we have explained, the community action was not included in rehabilitation. Besides the rights of the people in the hospitals, one of the things that we have identified regarding stigma discrimination, considering that is stigma, not only self-stigma, but the public and family stigma, the stigma from all the sector, is that the people taking care of them and the people ensuring that service and ensuring that protection on health issues was an important part when identifying where the stigmatizing people were located. It was the nurse, the person taking care, they were encouraging this stigmatization. That's within all the actions included in our path to face this reality. It is precisely that within that health promotion, we have to train in an integral and coordinated way, first finding the importance of protecting the rights to consider that person as a human being, and then any other diagnosis and everything else. Being transparent, we may say that the challenge that we have as a country in the Caribbean with the strength and the opportunities that we have, but also with a lot of challenges, with a lot of work to be done, we may say that even with these precarities and even with all this slow starting on the operations, we try to visibilize the mental health based on the fact that it is considered like an epidemic. Well, now we are working on the reactivity. We have ensured access to psychotropics, the essential ones. We are one of the countries that we have access, despite that the pharmaceutical industry and prescriptions are playing an adverse role, even though the challenge is that we have an investment that is below the ideal one. According the guidelines, we have an investment of 1% for mental health. What we made, and I want to emphasize this, is to identify the statistics that allow us to see the illness load, to have an analysis of the epidemiology in order to face this reality, and within the events that were defined by the regulating entity through the General Direction of Epidemiology and Mental Health, is precisely that the events associated to mental health must be considered as mandatorily notified, so that we may know where are the illnesses which are the most vulnerable groups, and within the main events that we have. For example, this mandatory notification is the part of depression, the anxiety general disorders, the trauma post-stress disorders, suicidal behavior, violence, mostly when we have survivals or when we do not have survivors. And something that from 2019 generated a lot of attention is the fetal alcoholic syndrome, mostly with incidence in a lot of pregnancies in the country. This is how the network is formed to provide this service to all the population with a mental health issue, but also the service to all the population based on prevention on mental health disorders. And let's mention that we had a model where we have these mental illnesses hospital, where you went over there and leave the person with these illnesses already diagnosed, and then you forget about that person. But we have been moving, thanks God, and thanks to all the effort of the committed people and the authorities. Today we can say that we have more integration regarding the provision of the services and to ensure the rights contained in the legal part. Right now, we have prevention and rehabilitation of addiction centers. We also have this center of contact of first aid in mental health, where people can call a person for an intervention. We also have these community centers on mental health, which was the starting point for the population and in the system, because by involving the community as part of the support for the rehabilitation of mental health and the prevention actions, that resulted in something good by sensibilizing, by involving, by generating a different actions regarding stigma, a different way of building, mostly including the general community and the family. We also have these diagnosis centers ensuring attention. We have the units of intervention in this crisis in the hospitals. Once we have a person with a crisis requiring an intervention, we have more than 8 intervention units, also the rehabilitation of centers. In the past, we had a hospital with a room. I'm going to mention it as it was for the people with a mental health disorder. But thanks God and thanks to the sensibilization and training, and by the authorities recognizing and being committed not to reincur in this stigmatization process, we also have these places where the people once diagnosis, they go over there and perform a duty, because this is very important for the people with some mental health disorder. And also these advisory services at the community, where we do a follow-up using that team to identify risk factors and also to intervene therein. Item A, the same status of stigma and in the Dominican Republic, we have been labeling a lot of people. That's what we were doing. We were labeling the people, but we were not taking care of the mental health ill people, but only general ill people. But now we are moving to ensure using public policies to ensure promotion and rehabilitation, obviously supporting the family too. The part of the stereotypes dividing we and them, as I explained, there is a group of people with this stigma that is not considered as part of our group in the community, and the whole set of everything happening regarding the people with this mental health disorder people. What you see in my screen, it's a center, it's a city, it's a rehabilitation center where we see the trees and where we strengthen the different skills of the people with some kind of mental health disorders. And we are doing some progress on autonomy as a responsible part of the system to ensure rights. According to the current approach, as part of the psychosocial approach, we have been moving to the proposing part, to the reactions and not only reaction. And we have identified the different risk factors. We are working with the international guidelines. We are trying to strengthen training to the people providing the services. And in one way or another, we have identified that this is a biopsychosocial problem. And we know that a lot of people have these disorders. Here we can see the health staff having contact with a person in these crisis centers. This basically is breaking all the stigmas. That is ideal for everybody here and for everybody attending this Congress. And I would like to say goodbye using this phrase and with 3 images that I want to talk about. The first one is the strategy that we already mentioned. We as a country with PAHO and the WHO, we are talking about intervention, transference, training, transference of knowledge, right assurance. What do I mean by this? With the image gap. In the past, when you saw a psychiatrist, it was considered as a situation with a barrier in the access because we didn't have enough human resources, and the mental health disorders were not considered, and that was considered as a limitation. The psychiatrist had to visit a lot of the patient and provide the drugs and to take care of the family, and that was a limitation too. By ensuring training, transferring training to the local teams, now the local teams may do the first intervention, may have the tools for the interventions to do it on timely basis and to have more participation in prevention. The second one is that we have an issue with the women killed. In the lower part, we can see a person with no diagnosis on mental health disorder, but then he started to go out to the street and showing something like this, that reads, be mad about your woman. Then a lot of people saw it, and he is dressing like that, he's still dressed like that because we couldn't understand how a person dressed like that could be showing a message like that, and that caught our attention. And the last image is about the campaign that we worked in the 2019, where we talk about the primary attention for mental health disorders in the Dominican Republic, creating social networks, contact service, and we created a lot of actions. And we also had posters along all the country to have an effect on those statistics, but mostly addressed to the young people, because we saw these high statistics on suicidal behaviors, because they were not receiving help, because they did not feel comfortable expressing that they had this mental health issue. With all the features that we have in the country, we can talk about the many challenges. I just want to simplify them as, I'm sorry, doctor. I think we have to close because of time matters. Thank you very much, Dr. Laura. Yes, this is the last one. The regulation of implementation to consider the current legislations, the approach oriented on eliminating stigma and discrimination, a budget warranty that may allow us to have a better articulation and response, the integration of mental health services, not vertically but horizontally, the participation of the people living with this mental health disorder. To take away the stigma on mental health is to build social security, embracing people. Unfortunately, we have to close. This is very important, but I think that we have to close with the three phrases. Let's talk about the social contact. Let's question the different vulnerability of people suffering violence, and then learn about the good practices as those shown. Remember, this is not a privilege, it is a right.
See you soon. Let's continue with the next activity. Thank you, Mrs. Marcela Velázquez Bolio. Thank you very much to all the participants. It is very important to have this international roundtable. Now we will give the floor to Dr. Castillo so we can move on to the next subject. So we are happy to introduce the debate, expectations and results of transversality and intersectoriality in mental health and addiction. To do so, we appreciate the participation as a moderator to Mr. Jose Antonio Alcocer Sanchez. Mr. Jose Antonio Alcocer is a dentist. He has a degree in law, postgraduate studies in investigation in health research, hospital administration, and a master's degree in hospital administration. Within his trajectory, he was a representative of the government of Tabasco in Mexico City when it comes to medical services of Nacional Monte de Verdad. He was a medical aide in Los Encuentros del Centro, and he was also part of the Mexico City patronage in the youth integration centers. He is currently the director of the Institute for Addictions and Prevention in Mexico City. Thank you very much for your participation. Hello, good morning, everybody. Good afternoon. So in some other places, I really appreciate the opportunity of being part of this third Mental Health Congress. It is very important for us in Mexico City, but for many aspects, we are extremely excited. We'd like to welcome you to the assistants on behalf of IMSS, the Social Inter-American Social Commission for Mental Health, PAHO WHO, Opedem's Bienestar, Fundación IMSS, and us as an institute for the prevention and care about addictions in Mexico City. Welcome to this activity called Expectations and Results of Transversality and Intersectoriality in Mental Health and Addictions. On behalf of the governor of Mexico City, Dr. Martí Bartes Barrama, the Ministry of Health, Dr. Arellano, we would like to greet you. And we are very excited to carry out this third Congress. So the purpose of this third Congress in this section has as a mission to critically assess the challenges and successes in the current policy that have shown their improvements, as well as looking at the improvement areas and considering the long term so we can be innovating constantly in mental health and addictions to provide proper care of the population. We're also going to be looking at the expectation and results in the intersectoriality and transversality in the region of the Americas. So we congratulate you and we greet you from this virtual scenario through social media in the platform that is allowing us to hold this Congress. I'd like to congratulate Dr. Gaitan. He is the head of the National Commission of Mental Health for your commitment on the transformation of mental health and addictions in Mexico, as well as Dr. Galinda Barron, National Director of Mental Health, for your constant support and enthusiasm so Mexico is ahead in this matter. I would like to now introduce the experts that are going to be part of this debate. They all have exceptional backgrounds and quite a broad knowledge in this matter. We have Dr. Carmen Martinez Viciana. She's the Regional Advisor of Mental Health and Substance Use for Central America, Caribbean, Latin and Caribbean, and Mexico from PAHO and WHO and the Dominican Republic. Thank you, Dr. Carmen, for being here, as well as Dr. Gonzalo Sotobrand. He's a Minister of Health in the Metropolitan Region from the Ministry of Health in Chile, Dr. Soto. Thank you very much. Mr. Ulises Rangel Cruz, he's the coordinator of the technical group in the advisory of prevention and the Deputy Ministry of Health Promotion in the Ministry of Health in Mexico. Thank you, Mr., for your participation. And as we have seen, the methodology or the system in this roundtable, it's essentially a 15-minute space so that every expert gets to talk about their work experience in the region. And then after their presentation is done, we will carry out 3 presentations to address the subject. Let's start with our first speaker, which is Dr. Carmen Martinez Viciana. I will be reading her bio. She has a master's in public health from the European Canarias University in 2016. She has a master's from the Deusto University with a focus on human rights and health, postgraduate studies in the international health from the Catalan University, as well as a degree in psychology from the University of Barcelona. She is currently an advisor for PAHO, WHO, for Central America and the Caribbean. She has quite a lot of experience, and she has been working both in the field and theory across 25 countries in Latin America, Africa, and Asia in advisory and managerial programs. So we would like to give you the floor, Doctor, and thank you for your words. Good afternoon, good morning for some of you. Thank you very much for the invitation. It is a true honor to be part of this Congress as well. I like to again thank the teams and the rest of our collaborators and Mr. Antonio Gosset for the introduction and for moderating this panel that I believe it's very important in general nowadays. I am going to share my screen. Please let me know when you can see it. Yes, we can see it now. Thank you. So, within this matter of the expectations and results of transversality and intersectoriality in mental health and addictions, as a representative in this case from PAHO and the regional WHO office, I would like to talk about the elements generally and how we're working towards the technical cooperation in this regard. I will be talking about some elements and why it is so important to have this transversal and intersectorial perspective in mental health. I will talk about some main guidelines on a regional basis. I would also talk about some examples on the initiatives that are being carried out in the region, and I will wrap up with what is essentially a proposal of the very baseline of the path to follow. I believe it is essential to start talking about the factors related to mental health. These essentially might have a specific when it comes to health, but they are essentially the same ones. Of course, we have some different perspectives or emphasis, some highlights that we would have to address. But in a general matter, in an international perspective, it goes along the public health perspective. We have macro elements like the socioeconomical factor as well as the political factor, the governance model and the moment politics that includes key elements like macroeconomics, health and whatnot, the regulations and the morals of the baseline morals in the society, the different sectors where we can find the key determinants like the economic income, job, income in general, sex, race, ethnicity. And when we address more individual-based elements and family-based elements, in many cases, due to the connection, we would find material context, social matters, psychosocial matters, conduct, behavioral matters, and biological matters. And all of these are contributing in the distribution of health and well-being and in how the system for mental health care will work. Always hoping that this is universal. However, this model allows us to determine these or to showcase these complications. So before moving forward, I would like to basically talk about an example. If we think about the socioeconomical context and political context, how is this somehow indicating clear or outlining clear instances of family income or an education of an individual and the material circumstances? This will lead to the understanding the possibility of mental health care access. So I wanted to also mention the risk factors and the mental health prevention aspects. I won't stop too long in each and every one of them. I believe that we also bear in mind the individual, community, and family baseline as well as the structure. I was thinking about this specific example as it could be a teenager that is exposed to this low education level, that does not have a proper diet, which will then bring obesity to the factor or other chronic diseases and comorbidities. They are also not satisfied with their body, they're uncomfortable in their own skin. And if we think about other related factors on a more community and family level, we can see that this person this teenager is exposed to violence on their family. There are also some complications with job access in the family. So these would also lead to some key structural factors exposure, which might be the lack of access to utilities or the risk of undergoing some emergencies that another teenager wouldn't be exposed to. Now let's talk about the other factor, which is a protective side. I then again won't focus too much on these, but let's bring an example to the table. Let's think about a teenager that has a different life situation. This person was able to develop emotional and social skills with great support from their family and from the educational center that they went to. They carry out physical activity frequently. And since they were small, they had the possibility of having proper nourishment. They have a good support network from the society, family, and whatnot. They can really rely in meaningful people that will be aware of their situation, and they have economic security in their family. And this allows them to have access to protective and health services. This entirely changes the situation in either case when it comes to how is this person going to deal with mental health based on all of these factors involved. Obviously, there might be others, regardless of those baseline factors that can be developed. We can see others in this teenager. However, we're going to have an advantage or a clear disadvantage. So to talk about the multi-sectorial, the multi-sector and collaboration-based factor, if we think about the people that have any sort of mental illness, that will require a series of elements that could be involved in their mental health, despite this person having the high quality care, they might not be able to have a generalized human resource if they do not have financial support, a place to live that's dignified, a job that might imply that this person will have a specific set of support, but the possibility of having a job, an educational support, a community support that could be formal or informal on social protection, and different legal protections. It won't be the same for this person to live in either country, where you would see different regulations. So we have this weird chart where we can see all the different interaction between elements that are involved with services directly for mental health services, health services in general that this person might require, but also all of these services that come on a different sector. So these factors, risk and protection factors, are important in stability situations, so to speak. However, if we think of this specific emergency situation, the scenario is even more complex on this level. We know that 1 out of every 5 people that had been exposed to an emergency situation in the last 10 years will face a mental health issue. Essentially, what we hear nowadays, the evidence suggests that this person will be having PTSD, depression, anxiety, bipolar disorder, or schizophrenia. And in this regard, the mental health work and psychosocial support before emergencies require components in every single moment, from the prepping of the response to emergencies, the response itself, and of course the recovery post emergency. We'll take a look at an example later on. The COVID-19 pandemic was a very obvious example where we showcase or we saw this mental health crisis that kept on increasing. In 2020, we saw an increase of 35% in major depressive illnesses and generalized anxiety issues due to the pandemic. There was a generalized impact in the population, but there were some groups that were heavily accepted. Of course, healthcare workers and the people in essential or first line workers, women, young people, and people with specific conditions like LGBTQ+, mental health patients that were already seeing an issue in how to maintain their treatment, some specific racial groups and minorities, and people that on a socioeconomic level were being especially affected. As a quick overview, we should remember that climate change is still an issue. We cannot ignore the obvious impact that we are now seeing as an evidence that how it showcased in mental health, the acute and the emergencies related to climate change and long-term issues in climate change has increased frustration, anxiety, and suicidal behaviors. If we focus on the essential matters when it comes to the healthcare sector, we would see obviously the healthcare provision as such, provision and prevention. And we have two main aspects where transversality and intersectoriality has major roles. The health world cannot work by itself. It requires this collaboration. If we are not working with social protection, a livelihood, with prison systems, if we do not cooperate and collaborate with many other sectors, it would be very hard for us to have real access and a real state of health care provision. And in this regard, it's also essential to support any initiatives that are connected to this. We can see this little house, and this is a clear example that we should support the right of proper livelihood to the people with mental health, because it would change the whole scenario for this person. So now I'm going to briefly talk about the current policies and mandates. We have been seeing them in other sessions of this Congress. That's why I wanted to just bring to the table those that are related to this subject. The new policy for the mental health improvement on a regional basis. This was addressed last year and it was approved last year by the member states. It basically mentions the relevance of working on governance, leadership, and multi-sector, cross-sectional alliances, and bringing in mental health to every policy. I think this is a really good summary, and at the same time, it brings many challenges to the table. Last year, we also had a high-level committee on mental health and COVID-19 by PAHO. We had as president Epsi Campbell Barr, ex-vice president of Costa Rica, and the co-president was Nestor Mendez, who is and subsecretary, general subsecretary of the EAO. We had other members from the academy and from the mental health world, and this committee finished with this final report, wrapped up with 10 specific recommendations. These recommendations that it's a so-called new agenda for the mental health of the Americas, has 6 transversal principles: universal healthcare, human rights, equality and no discrimination, focus on the life path, empowerment of the people with mental health issues and their families, and multi-sectorial collaboration. So I believe they are self-explanatory, and we now have a very clear focus on the importance that this collaboration system is acquiring when it comes to working across sectors. Among these 10 collaborations, or among these 10 statements, the second one says the integration of mental health in every policy to promote integration in the healthcare world, but also other sectors, just as we have mentioned before. And in the response before emergencies and disasters that were still a little bit of a matter that was still pending in many instances. This recommendation has 3 access points. Action point, incorporating mental health in other priority healthcare areas. I could mention mother and child health, TB, and many others to integrate mental health in policies of other sectors, as we have mentioned, employment, social protection, education, so on and so forth. And last but not least, to integrate mental health in the response before emergencies and disasters, like we mentioned before, that we have heard before. In June of this year, we have an approval of the strategy to improve mental health and suicide prevention in the Americas. And we also have, out of the 6 strategic lines, 2 of them are quite connected with what we're discussing. The first one says to foster leadership, governance, and multi-sectorial collaborations and integrating mental health in all the policies. We're repeating ourselves. That's how it became solid. And the last one on the suicide prevention as a national priority, creating this multi-section capability to address the needs of the person that are affected by suicidal behaviors. Very specific matters that come with the reinforcement of mental health in human rights matter, increasing the capability of achieving this protection to their human rights and reinforcing the laws on mental health based on rights in many countries. We would like to mention that both Bahamas, Guyana, and Paraguay, and you're very aware of Mexico's action. They have been approving in the last years some reforms to mental health matters, or specific ones, as the ones mentioned in the Congress, the reform to mental health on the general law in Mexico. They're working on the key points in this part. There is quite an interest on many countries of the region. I think it's important to highlight and also talk about the need of support between countries, the importance of integration of mental health in the first level of care. In primary care is a focus as well. We have also been talking about many training programs in the MH gap to reduce the gap in mental health care. We are supporting 25 countries right now so they can develop these sort of trainings. And we have over 150,000 people that have received these training. I'm sorry, doctor, we're running out of time. Okay, I'll be done in just a minute. So the example that was also given when it comes to the integration of schools with projects like reinforcing educators and teachers themselves in the basic knowledge on mental health at schools, as well as the reinforcing in the mental health and psychosocial support before emergencies, working in cross-sectional systems in all 16 countries that are working in this regard, as well as the development of capabilities and taking care of the mental health care the healthcare providers themselves. I'm not going to delve into the major strategies, but those are highly connected with the cross-sectional collaboration. For instance, the access or the restriction in access to plaguicides. We have also seen other examples in substance use, where we're looking at the safer strategy for the alcohol consumption that has key elements that are not necessarily a responsibility of the healthcare sector only. And just to wrap up, the pathway to follow is about awareness in all of the levels, in every sphere of life and along the life cycle, and for all the sectors that we have mentioned. It requires a political commitment that also includes financial and human resources, so that this collaboration is efficient, and that comes with not only when it comes to political public policies, but also these human rights and community-based focus. Thank you.
Doctor, thank you very much. We thank your excellent presentation, considering your experience, making so clear that these risk factors are determinants of mental health, the social part, this political part, determine what we have to do, because we can also see the importance of having this multi-sector involvement. Doctor, thank you very much. Now we have Dr. Gonzalo Soto Brandt. He has a diploma on integration of the social determination for health and formulation of health programs by the Latin American School of Social Sciences, a diploma from primary attention of health, a master on public health in the public health school in University of Chile, psychologist from the School of Social Sciences. Currently, he is Ministry of Health in the region, in the metropolitan region. He has been the coordinator as academic on the mental health and community psychiatry in the University of Chile. Coordinator mental health in the primary attention division in the under Ministry of the networks in the Ministry of Health, advisor in the subsystem of Chile, and consultant in the Pan American Health Organization. Doctor, thank you very much for your presence, and be you welcome. Thank you very much, Dr. Alcocer, and also thank you very much for organizing this important Congress, and I am so proud to share with Dr. Carmen Martinez, and also with Ulises Rangel, coordinator of the technical group and advisor of the prevention and promotion under ministry in the health ministry of Mexico. And now I'm going to share my screen with the presentation. Hope you can hear me well. And now I'm going to share my screen. Hope that you can see the screen. It is quite interesting to share this table regarding the intersector work. These are some of the aspects that I think that are the most important that we have ahead, mostly after listening to Dr. Carmen Martinez. These are the expectations and results. I would like to express in these brief minutes what is happening in Chile. Well, we are very hard working regarding the challenges in our country, because it is the governance. Because in the health ministry, well, we have this important effort to harmonize all the agenda, which is not exclusively for the Ministry of Health. That's why we have to root sheets for the implementation of mental health. It is the result of the work of more than 1,000 people working all along our country, experts, technicians, academics that work in this mental health program with several lines of action, and President Boric, because for him it is very important to say that he's very focused on these mental health disorders. First of all, you can find this program in the internet, and you will see that this is quite explicit. A priority for Chile is to approach the mental health disorders. We have different strategies, and we have a lot of challenges. And I have to mention it because he has been the first president in our country that is working so hard on mental health disorders. As Dr. Martinez said, yes, of course, the pandemic affected mental health. So we had this evidence for a multi-sector approach. President Piñera also made a movement to approach mental health intersectorially with the program of the current government. This is explicit and this is a reality for the country. I would like to comment some general conditions, and myself as the Ministry for the Metropolitan Area, I think this is very important. And this is the principles for this program. And I want to talk a little bit about that based on the rights of the people to live in an environment that is good for them. So we have to approach the determinants. And that is not possible if we do not work with all the sectors and with all other actors, not only the government, because sometimes when you talk about intersector, you say about the municipality, the sub-regional, sub-national entities, but the intersector work is involving the participation of the social society and not only the public sector. Also, to include health in all the policies, because in fact, we must have a cross-section approach with this link in participation. We have been working in the implementation of this program, and it is important to say that we have been strengthening, but still there are a lot of gaps to be addressed, and also to talk about the populations that may be vulnerable. It's not a vulnerable group, it's not that you burn it there, but it's like we have these vulnerable situations and you may fall in them. Now I'm going to detail a little bit all the challenges. First, it is one of the first priorities for the Chile government. Second, as mentioned by the president, to generate all the strategies so that in the most integral way we may reach this limit that the people do not have the need to face problems to have access, and also to have the policies that may allow to accompany and to support all the people. We have a lot of legislations just implemented. And for example, the number of hours worked by workers every week. We already approved a law on that regard because we know that a determinant for mental health is work and reducing 45 to 40 hours per week. It's a law that was passed under the leadership of our president. Also, to approach the social determinants of the health, all the life conditions impacting mental health, and of course, to know how to approach it. But based on a community model, what has to be done in the community, in the first level of attention, that's where we must have all the general policies, and we have to improve on the processes. Some examples, I would like to share this. This is the agenda that we have currently. Let's simplify them. First, the strategy building mental health. These are many of the aspects included in the government plan. First of all, to strengthen and the leadership in the intersector governance. Part of the strategy was to have an advisory board, as we'll mention in the next slide, including the academy, the government, in the decision making at the highest level of the government. Second, to improve the mental health services. This is a challenge as a country to find all the determinants to improve our services based on the MHGAP model. Of course, we have a lot of challenges, but this is a strategy based on the community mental health, based on the community as a center of the mental health. Also, to talk about promotion of mental health. The policy strategies included, for example, we have a picture showing the health of our country, Dr. Aguilera, with a governor and the director of the Bajo in our country. They are painting a bench on green color, which is part of the strategy, because they have been leading these works. We have also working on that, and the president himself has led these campaigns. He has been in the same campaign, in the same government processes. And he has shared that he had mental health disorders. That is why it is very important to have these examples. For example, our president talking about his own problems, because we must know that these are problems that we may experience in our life, but we must generate the conditions to overcome them. We also have this prevention of suicide, working together with the Service of Addictions, Comiloga, and with the regional governments. The regions, in order to join their efforts, in this case, working with a telephone line to take care of the prevention of suicide and other programs that we have in the metropolitan area using some lines like WhatsApp, of course, to strengthen the emergency response. In Chile, we have a lot of emergencies. Right now, we have some fires. We also have a rain in the high mountains. And I know that many countries in the region have these kind of issues, but we have to integrate mental health in these kind of processes, not only by the health sector, but also other sectors to support the region when we have an emergency situation. And of course, to work with evidences and investigation. We have to shorten this research gap, prevalence, incidence, coverage. This is a very interesting and important work. What I just mentioned, this is part of the agenda that we are working as a country, as a government. In the metropolitan area, we have a huge challenge because the big number of population to strengthen things such as the participation. For example, we have the advisory board. On the right, you can see the two on the Ministry of Health that are working very actively together with the Ministry of Health. They are in the currency palace. We also have the Ministry of Health. They are experts with experience. They are working on mental health. They are academics. And this board advising the government about the guidelines to be included in mental health, not only in the health sector, but in the different portfolios. That's why we have this picture in this place On the other side, we have what we have included in this government plan. We must have a new integral law on mental health. We have a partial law with a lot of positive things, but it was only partial. Now we are doing a big effort to have a new mental health law. In the other picture, you can see the president leading one of the sessions with the public, with the adolescents, with the participation of more than 1,000 people. And based on those dialogues, so we created the project for the mental health law that will be sent to the Congress. But it is already done by the Ministry of Health, and now it's going to be sent to the Congress. We had a dialogue in the whole region with the participation of users, patients, people, social society, academics, experts, workers. In general, which are the most important access to have this kind of laws? Well, one of the most important aspects is to improve the governance with a better integration with other sectors, and regarding demand to improve the service delivery, and also to improve these dialogues with the original people at intersectorial level, and also with the migrants that we have in our country with the sexual diversity population. We try to have the best diversity we could, also with a regional belonging. We have 16 regions in our country, almost 17 million people. I know that time is short. Thank you very much for the invitation, and I would like to continue contributing in the table. Thank you for providing me this opportunity to participate. Doctor, thank you very much for your presentation. It was really outstanding. We can clearly see that Chile has this humanitarian view, this including view, always abiding to the human rights of people. And we can see the community work that you are performing in Chile, because this is the best way to reach people. As it was mentioned by our president in Mexico, less death and more territory. That is the best way to reach people, not to be waiting in the doctor's office or in your desk, but to go out to the communities to see the needs of people. And I can see that you are doing it in a very good way. Thank you very much for your participation. Dr. Gonzalo Soto. Now, to continue with our program, we are going to introduce Ulises Rangel Cruz. Thank you very much for being with us in this third Congress on Mental Health and Addictions. Ulises Rangel Cruz has a title from Politics and Governance from the Monterrey University. Right now, he is a coordinator of the Advisor Technical Group in the Under Ministry of Promotion and Prevention of Health. This depends on the Federal Ministry of Health that are doing so many changes. His experience is part of the advisory technical group of the Under Ministry on the Prevention and Promotion of Health, and is sub-director of priority projects on public health. Be you welcome. Hello, good afternoon. I hope that you can hear me well. My greetings to everybody, to all the attendants. And thank you very much, Dr. Alcocer, for moderating this space. Dr. Carmen, and Dr. Gonzalo, I was very pleased to hear your experiences and your presentations. And I greet Dr. Evalinda Barron Velázquez. We are family in the Ministry of Health. In the past, we were working together in the Ministry of Health, but right now, thanks to CONASAMA efforts, we have a commission on addiction and public health. To that extent, as we are family, we have been working very closely in this intersectionality and about the approach of the commercial, political aspects of health. For public health, it was really an honor that the experience that rendered more learnings was the national strategy for the prevention of addictions, together for the peace, which is in the territory on the health matters. Thank you very much. Can you help me with my presentation? Thank you very much. Next one, please. Specifically, I'm going to talk about intersectionality in order not to cover so much and to provide so many details. I'm going just to talk generally on how we articulated this intersectorial. First, to tell you that we had a change in the paradigm in Mexico. As you may remember, in 2006 to 2012, we had a president that declared the war against drug dealers and which generated violence in all the country, and we are still suffering the results thereof. And President Andrés Manuel López Obrador, together with the team leader by Dr. Alcocer, decided to have this approach so that the strategy for addressing drugs was going to be managed by the ministry. So what we did was to put in the hands of the Ministry of Health the problems of mental health disorders. You can see that this has also to involve the National Guard and the Army. But regarding the demand, as mentioned by Dr. Carmen, is to see the biosocial ways and psychosocial ways. Now, what we are doing is not to stigmatize the people or the users, because we have to stigmatize the usage, the problems, or the situations that make us vulnerable, that make vulnerable the young people or the LGBTQ and plus and Afro-descendants and to women and to other groups that are vulnerable and that exist in Mexico. Then for the Under Ministry of Public Health and CONASAMA, we have two very important dimensions. In October last year, we have something that it's called Plus Bienestar, which is another strategy followed by the government of Mexico to fight the decentralization of the health services and the lack of development in our national territory. We publish this program that has two things.
Because the Supreme Court acknowledges that the right to guarantee healthcare protection in Mexico has a collective dimension. And therefore, in the legal side, it provides us with a framework so that every social factor is involved. This is the understanding that we have from Mexico. Traditionally speaking, we have associated these mental health and addiction matter. I mean, in the best case scenario, from the clinical and medical side, you know that Konasama has been carrying out many efforts that they will be sharing later on, probably in the mechanisms of this meeting, you'll be able to access them. But Konasama has been doing an extraordinary job in transforming the healthcare service provision so that whoever needs to access the system altogether gets this opportunity. It's closer in a more community-based approach, eliminating these themed hospitals gradually and incorporating uh, rooms that are right in the general hospitals. We have changed this vision along the year, and we have understood that granting this right goes beyond providing mental health services. This is also related to education, livelihood, job, and culture, a little bit what Dr. Carmen mentioned. However, I do want to be very emphatic here. I want to highlight so there is no room for questions. We live in Latin America, and Mexico is one of the countries that suffer the largest amount when it came to corruptions and social and economic inequality, the lack of access to some services, it's abysmal in many regions in the country. And talking about social factors, it's not just this fancy word from the theory of public health. There is people that live on the landline. There's lives that are valid for the state. There are some lives that are not valid for the states. There are some lives that we don't have a use for, and some others we do. This sensitivity is the one that we have to bear in mind when we're talking about social factors, and this is the sensitivity that we're looking to focus these addiction prevention strategy to. So we said, okay, how do you do this? How can we perceive when it comes to not it being just an idea? To say that social factors are tackled because there was a training, because there was a conversation, because there is postgraduate stories or training groups. The point would be to address the causes. And the national strategy for the prevention of addiction says that it encompasses the priority programs of the federal government to address the root causes of substance use, generating development opportunities, promoting community values, and addressing the community, family, and personal causes. The Mexican government has provided to the population a ton of programs all along the federal government that go from support to single mothers, scholarships for people that are not working or studying, scholarships for women, pension for elders and the people with disabilities, a series of social, cultural, and regional elements that are coordinated from the Mexican Institute for Youth, from the spokes office of the presidency, coordinated as well from the Ministry of Health, from promotion and prevention for health activities, from the National Commission of Sports and whatnot. So we have a progress, the left to the public health element, and we say, okay, how can we bring in all of these social factors and use them? Well, we should start using what we already have, and that's why we're saying that it articulates the major programs of the federal government, that I will elaborate on this in a minute. Before this, we thought that as an interdepartment group, across department group, we believe that we needed some principles for the articulation of the department collaboration. And this goes from theory to practice. And we said, okay, this is the criteria where these cross-governmental relationships are based off, we could say. So these were our principles. We were looking at bringing territorial justice. The point would be to recover what's common and what's public. The spaces, lands working with the farm ministry, with SEDATU, and the programs of improvement of urban areas in marginal zones, the recovery and generating mechanisms for peace. I believe we have two very important elements in Mexico. One of them is the table for the coordination of peace, which is led by the citizenship ministry, and it helps in matters of security. And the other one that I believe is also as important, it would be the workforce for Together for the Peace strategy. I want to acknowledge Dr. Evalinda and her team that achieved the creation of this task force across all of the country. These these workforces, what they are creating, it's a space for dialogue in these matters that start adding up on the state and delegation workshops for the federal program. So the coordination is not just on a federal basis, but it actually landed in a workforce that is regional, so that the Ministry of Health and the Sub-Ministry of Health and the Ministry of Security also links the State Council for Population and the Prevention Strategy for Teenage Pregnancy Prevention, and many other elements like the youth state organizations. So we have a mirror there where we're generating these mechanisms. And why? Why did we do it this way? Because we do not assume that the information drops down. It is a mistake to think that if you're not organizing the intergovernment organizations themselves, they're just going to drop down. This is not how things happen. We have to create those spaces and tools for dialogue. We also think about cultivating well-being as one of the articulation principles, because we try to name all of these elements focused on well-being within the system, the state of well-being. So that's why we were investing things in here to generate the social causes and thinking of these Orwellian police state that requires intelligence for dismantling this and that. Yes, maybe we do need intelligence for the dismantling of trafficking, smuggling, and other networks. But how about we focus on the well being of people first? This is the main goal of the state, after all. So we are obviously a government that has to show results. And the first 6 years of the four transformations. So we have a comprehensive system that it's articulated after the cross-referencing and the cross-powers of this collaboration. We have some territorial units where these things are happening. It could be a neighborhood, a municipality, a state, a couple of municipalities and whatnot. It could be even a doctor's office or a hospital. We need to geolocate these spaces and see where our uh, install activities are cross-referenced before thinking, you know what, let's just sweep the entire country and let's start over here. Let's see where we are already. These are some of the examples of those instances that are participating in the strategy. Can you help me with the next slide, please? This is where we'll find them in a more a clear way as intervention blocks, or more like action blocks from the state. We have the urban improvement from the civilian protection ministry. This is a great program. If you're not from Mexico and you don't know about it, please become familiar with this urban improvement project. This is a big investment in public spaces in the country. The Institute of Social Economy, the Ministry of Work. Inside of the health sector, of course, we have the biggest healthcare provider with IMSS, the National Center of Gender Equality and Reproductive Health, and all of the elements that these center is offering when it comes to safe abortion, family planning, the centers of youth integration, the Sencidazo Center in charge of prevention of AIDS and HIV, as well as other STIs that offer free services in Mexico of providing antiretrovirals and post-exposure medication, as well as prevention systems for the prevention of hepatitis C. We're very proud of sharing these across the region. The Ministry of Culture that we'll talk about later on, and another big amount of participants. So think about how these meetings started. And I'm just gonna talk about this because I think it is important when addressing this topic. It was complicated. We had these high level meetings from all the states and institutions that just couldn't agree with perspectives, with conclusions. We reached some agreements, and we started with the workforces, and they tried to land this in an operational document. So we started moving, and we had nothing left but moving in the field and being with the people. Can you please show the next slide? So one of the exercises that became really helpful was this, indeed. How does this intersectorial system works across the different states? We were identifying some risk factors, like there were the lack of safe public spaces, and the protector factor of this was the communication. In this regard, for instance, Mexico has this urban improvement program that comes from SEDATU. So these incidents, this direct element on the risk factor leads us to create an action matrix where we can develop indicators and targets all together. It's the family factor in the protection area, and we have the protection to mental health. We don't have anything specific in the community for, oh, well, the issue was there was a lack of jobs for young people, so we have a program that addresses it. The chauvinism, the protective factor is community-based, the program is called Equitativa, and the ministry is a culture ministry. And maybe you don't have a life project as a risk factor on an individual basis. The program, it's Territorio Joven, and it's the Mexican Institute for Youth, the ones that are addressing it. So for each and every one of these programs, we identified how this cross-sectorial work would work and how these social factors that felt almost invisible looked like. And we also complain a lot about the lack of information. I'm sorry. Dr. Eugenio, please, can you mute your microphone? Thank you. So it's something that felt intangible, so we decided to work on it and build this matrix. Please move along the presentation. I have some photos here on how this cross-sectional work looks like across the territories. And this is what I meant when I was talking about territorial-based actions. We have a community of people working on something that has an excuse to bring things together. It could be art, it could be the peace culture, culture itself, family planning services, prevention to suicide, training, so on and so forth. There is an excuse for associating, for collaborating in a specific unit, like a club, like an identity. So that's what we think it's the biggest lever that is allowing us to reach people. Sometimes we forget that the state was violent, that the state vulnerates, that the state might not be earning the citizens' trust. So we need to create alliances, just like Dr. Soto mentioned. It's not a cross-sectionality if we are not participating with other sectors of the population. That's not the state. And I think it is very important. Next one, please. So I would like to give here some numbers. And the culture as protective factor, 329 seats and 245 municipalities with around 12,000 minors, where they are creating different art classes and cultural expression classes. And at the end of the year, they carry out this final test, so to speak, at the Auditorio Nacional facility here in Mexico City. Next one. Now, as the youth as an agents of change, I couldn't possibly mention all of the programs that the Mexican Institute for Youth has. They are extraordinary. They have these contact program, close contact program, peer-based, that I think it's amazing. That it's virtual and it was built after the pandemic along with Asalma. We train the youth that are part of the program, and they help other young people that will call or send out a WhatsApp, and they got to identify these risk factors. And the best thing is that they address them to the proper need, to the proper help, and we have a follow-up. We managed to do this with the sector. I would also like to mention that this program is also in collaboration with UNICEF. The Ministry of Government that coordinates all of the efforts when it comes to peace and social reconstruction, social tissue reconstruction programs. They are also looking at equality spaces, they eradicate violences. Remember that they are also accountable for the National Commission for Discrimination Prevention and the National Coordination for the attention to women victim of violence. So the coordination with them is very important. So even though we have a change in strategy, also inside of the Ministry of Security, there was a reorganization and a change to look at the improvement of the peace culture, and it's also in the territories. Many of these people and teams displayed that are constantly in touch and working with the teams of the Ministry of Health. This is what I was mentioning about the National Commission of Sports. And in this regard, it is very important just to think about it. I don't know how long do I have left, but I'll rush. Okay, so this will be my last thought. Who has free time in this capitalist society, right? I believe this is a valid question from a state or organizational perspective. It's something that we should question, because sometimes we say, okay, just go for a hobby, go for occupational therapy or exercise, but who really has the free time? Who has the access to a space where they can exercise, a space that's safe? If you're a woman and you live in an unsafe neighborhood that it's not properly lighted, how can we carry out these sort of recommendations that are appropriate and adequate and sensitive? Next one. And yes, so this is where we can see the transformation when it comes to the supply of mental health services and addictions, where we transformed a couple offices. They were kind of working in these community centers for mental health and addictions, where we were looking at the goals of timely detection and care in a timely manner, updating and information when it came to addictions and guidance for the families and the proper guidance for other levels of treatment. This is what I mentioned as well. Next one. And this would be my last thought. Public health is a matter of every sector of the Mexican state, and the state as such should also involve the civil society. This is not only about doctor offices and hospitals, but also the community and their territories. So that would be it from my side. Thank you very much. No, thank you, Mr. Ulises, for this amazing leadership in the Ministry of Health in CONASAMA. We can see that there is this big change since the law change in 2022. And we can see that the National Strategy for Prevention, Together for the Peace since 2019, has seen real results. We can see this amazing cross-sectional work that is being carried out in Mexico with this amazing community system. And we can see the obvious benefit for all inhabitants in Mexico City, either users, non-users, people with mental health issues or not. This is a universal strategy. So I would like to congratulate you for this amazing job that the Ministry of Health has done, as well as the federal government and the National Commission of Mental Health. This integration has been amazing. Thank you. We're going to give a couple minutes. We have an earthquake in Mexico.
Intensidad estimada moderada.
Tenemos que desalojar el edificio, ya me imagino.
Estamos en proceso de evacuación. Coméntale, ¿no? Todo está bien.
Buenas tardes, aquí retomando, pues vamos a tener que concluir, lamentablemente tenemos que desalojar nosotros por cuestiones de protección civil y gestión de riesgos en el edificio.
Unfortunately, it was an earthquake, so we are concluding with the participation. We are evacuating the building. We have no much damages in Mexico City. We hope that everybody is fine. So we conclude this part of this debate table kind of abruptly. We are so sorry, but We want to thank everybody for your participation in this table by the Institute of Prevention from the Mexican government. Thank you all for your participation. Unfortunately, we are not going to be doing the questions and answers and conclusions. But I think that you can
In the
understand.
situation that is independent from all of us.
Thank you very much.
Good afternoon and thank you.
No sé si les dijeron, pero tuvimos sismo aquí en la Ciudad de México, entonces vamos a esperar a que se reinstalen.
We had an earthquake in Mexico City, so we have some protocols to follow.
Hola, ¿qué tal? Estamos de regreso, estamos de vuelta. Tuvimos aquí en la Ciudad de México una interrupción por un sismo que se reportó, pero afortunadamente todos estamos bien, actuamos con base a los protocolos y no hubo ningún daño, ninguna consecuencia y estamos aquí listos para continuar con nuestras actividades y para continuar con el programa. Agradecemos a nuestros expositores previos y a nuestro moderador por tan completas y enriquecedoras ponencias. Maestra Pilar Rodríguez, si nos hace el favor de presentar nuestra siguiente actividad.
Con todo gusto, muchas gracias. Les agradecemos a todos su
We
paciencia.
would like to thank you for your patience. Thank you for waiting for us. We will be back in.
Hello, thank you for waiting for us. Now we have Dr. Francisco Paredes Cruz that will be moderating the part of prevention and promotion of mental health in the working place. He is a surgeon from medicine school in the National Autonomous University in Mexico, a psychiatrist in the Mexican Institute of the Social Security, and currently he is a coordinator of medical programs. As a professional, he has been a psychiatrist in the coordination of assessment of health in work in OAD, Mexico West, and coordinator of the academic section of the Labor Psychiatric Association. Be you welcome. Thank you very much. Thank you very much, Dr. Pilar. Thank you very much for your attendance, and thank you very much for being for us, for being comprehensive. I am very glad to moderate this dialogue. Here we are including Dr. Ramos. I'm sure that he had some problems with the transmission with internet, and we have Dr. Mérida Puga. Dr. Mérida Puga, he is a surgeon from La Salle University, psychiatrist from the Neurology Institute with a Master of Medical Science from UNAM. He has a lot of experience on medical issues and also activities in companies. He has been working with the social prevention on labor matters, and he has also been working on addictive disorders in Ramon de la Fuente Institute. Currently, he is the coordinator of the labor, mental health, in well-being at ADN Mexico, and he is going to be participating in this important table because we are going to talk about the psychosocial factors and the prevention of mental health in working places. Dr. Mérida, really thank you very much to be with us despite this event due to natural disasters. Thank you very much. Yes, it's a pleasure for me to participate in this relevant event. It's one of the main opportunities that we have because we are committed with these kind of issues on labor. And this is part of the emotional demand resulting from these works. So here we are deploying these strategies to continue because we needed to continue conveying information on this regard. Thank you very much, Francisco, and also a recognition for your work on these matters. Here we are. It is my pleasure, Jorge. I really think that we can exploit a lot here because here what we need is to do a lot of promotion, a lot of evangelization. We still have to promote all these, mostly in the health centers. If you allow me, I'd like to express that when we had this COVID-19 pandemic, a lot of people didn't know that they have a health problem in general, but suddenly when we have the contingency and we have to find the strategies for the people, they realize that they had hypertension, diabetes, and general illnesses. And they realize that we have a mental health issue too. So what do you think? Maybe we can talk about these labor mental health issues. How can we do to prioritize mental health in the labor environment? Yes, in fact, the benefits that have been documented to promote the mental health at work is something that is already documented. And we can assign some categories to all the factors associated to the company, I mean in the organization. How do they get a benefit? First, we have to talk about the magnitude of the problem. We know that at work, 1 out of every 5 workers have a mental health issue. It means that the prevalence in this specific population of mental health is really high. If we consider that the prevalence on mental health in the general population is 1 out of 10, then practically the prevalence of these problems of health in this working population is almost twice as in the general population, at least when we talk about the Mexican population, which is very similar in all Latin America. This is something important. Now, therefore, to that extent, we know that at least 3 out of every 10 absenteeism days are associated to health, and many of them are associated to mental health. So the absenteeism that we have due to situations of family problems or situations associated, for example, to some visits to the doctor, at least 3 out of 10 are associated to health. So this is an important factor, an important impact. And besides, when somebody has a mental health issue, in Mexico there is a latency. I mean, to have access to specialized services are not good. And that is also important to include in the context. It is not only a problem where the person is suffering, but access is low. There are a lot of barriers to have access to the specialized mental health services. Therefore, it takes between 4 to 20 years, and problems for mental health that are very light and may complicate and become chronic. The absenteeism is part of the affectation to the organization due to mental health disorders. For example, a person with a depression may be absent maybe 14 days in their work, and a person with panic events may be absent 21 days in their work. Then the concrete benefit to prioritize mental health can be considered with these parameters, for example, the rate of absenteeism. On the other side, because of the nature of mental health disorders, a person with one of these disorders has low energy, low concentration. They identify with different movements, different ways of thinking. They may be irritable. And it has also been documented that the illness makes you to take bad decisions. These symptoms do not only generate absenteeism, and also the worker is at the working site, he's performing activities, but because of all the symptoms, activities are not well performed. Then the fact that they are present at work also has a consequence, as for example, they have a low quality in the services delivery, errors in production, errors in the production processes, interpersonal conflicts, a high turnover of employees because due to illness issues, they have to change to another work, and this result in a low retention of employees. It is important to mention that mostly for the new generations, the mental health programs at the companies are within the top 5 reasons why a person decides to go in a company. So it is not just preventing absenteeism and presenteeism, but also by prioritizing mental health, we are prioritizing the attraction and the preservation of personnel. Then, by prioritizing the mental health in the company, we will decrease absenteeism, presenteeism with a consequential important savings. For example, in the manufacturing area, in the Bajío area in Mexico, data show that not taking care of mental health has a cost of 11 to 15 million pesos a year. It means about six to 800,000 dollars every year. Then the beneficial effect for the company are the savings. And there is not only a saving, but it has also been documented in the international literature that the investment in programs to promote health have an investment return of $4 for every dollar invested. So these are the benefits that we have at the organizational level. However, we must also see the person. They also get a benefit. How? Well, in these environments that are favorable for mental health, we increase the safety perception. It means that I'm not in a violent place, there is no insecurity in the employment, we can see that the danger situations are contained. I do not think that it is risky. For example, in the case of an earthquake, we know that everything is established to take care of the contingency. Therefore, the sensation of safety is increased when you are in that working center. Another positive effects in the person, because we strengthen their support, their belonging sense to the company or organization, decreases the intention to resign, because this is something that people has this feeling almost 100% of the time. But we can see that when we have mental health promotion plans, that explains why we have a better retention of talent in those companies. And then in general, it increases the work satisfaction. I think this is important to be mentioned. The World Labor Organization informed that the main reason for death associated to work are associated to those already mentioned. Why? Because it is not a matter of time when you are exposed to this risk, but it's also the quality of the work, the quality of the environment where you are located, which can be beneficial or dangerous. It is also important, therefore, to mention this. But finally, but not less important, all this learning made by the person in the company if they participate in the mental health promotion programs, that learning is transferred to their home. So the positive impact is not only in the worker, but it is also transferred to the family. Let's remember that the Mexican population between 15 and 49 years old, the main reasons for early death and the days lived with disability, well, the main reason are mental health or problems. I think this is also important, a very important benefit for the people translated to the population is that you are saving days. You are saving days in living with a disability or affected by an early death. So these are the concrete benefits when we talk about this risk in labor. Yes, and we are receiving some comments. For example, they ask, what is presentism? Presentism in general terms is a person that is just checking in and he's just waiting to check out from work. It is a company, it's a person that is not productive. He just go, he checks in, he checks out, he's present there, but he's not productive. And sometimes we believe that that is an apathic person or a person who are not willing to work, but maybe it is part of a mental health disorder, as you just mentioned, Jorge. And then maybe we can ask, how can the company realize that in their environment that they have a mental health problem? How can they identify and approach all these factors? What can you say on this regard, Jorge? What is appealing about this question of how to identify and to approach, but there are two keywords, proactively and sustainable. And this is important, this deserves a reflection. Actually, there is a lot of activity or maybe a lot of intention to approach this problem, to identify it, but from a reactive perspective. I mean, with the amendments to the legal framework, standard 035, 037, the update of the illnesses table that include mental health issues. I mean, all these changes in the macro environment of the companies, of course, started the identification of the problem and to do something to solve it. That's not wrong. I think that everybody has experienced that, mostly those in my generation or above. For example, using the safety belt in the car. We did it as a reaction, not as a prevention. So it is not a bad idea to do all these adjustments, but to migrate this from a reactive approach to a proactive one, we need that the whole organization, that everybody understand the same, that they are motivated and to involve an affective part. It has to be consolidating a culture on this regard, not proactively, but by having this consolidation of the practices in the labor field. And this will result in sustainability. But in practical and concrete terms, I identify at least 3 areas where a lot of emphasis has to be done in order to move from reactive to proactive. The first one is that the organizations must include in their practices of corporate governance, they have to include these topics. I mean, the government internal entities, for example, the boards or the partners or the directors must be involved in the practices to identify and to solve these problems. Because sometimes they are delegating this to the technical subcommittees for their solution, but they are kind of distant in the communication and in the decision making, in the prioritization, because the board of directors do not participate. The first recommendation is that these members of the company regulating boards participate in the boards or in the technical committees to be involved in that. This will facilitate a lot to support the company in this kind of programs, and it will ensure sustainability. Another strategy is that these indicators, such as absenteeism due to mental health, or the events due to mental health as a root cause, as well as the qualification of labor illnesses associated to psychosocial problems, be also integrated to strategies of the company. If we do not associate the scope that the company is willing to have at financial level, then it will be losing the relevance, and they will not provide resources to this kind of programs. Another circumstance identified to make everything proactively and sustainability is that we must involve different levels, especially the people of human resources, professional development. I mean, we have to update these professionals. They must be updated on psychosocial factors, on mental health promotion. They must be trained because, of course, they are the ones who will be able to instrument these kind of programs in the company. And in order to identify them, it is important to mention that we have instruments that help us in the diagnosis. That's why training is so important. We have to differentiate them from the exercise made as a measurement in the organization. When you identify health risk, that is different. And it is not based on the organization, but from a different perspective with a valid instrument and with appropriate identification techniques. It is important to specify this. We really need a level of technical competences. And the third one, that I think that it's one of the most important, is that we will not have a proactive environment when we try to maintain these programs. They will not persist without a social dialogue. What do I mean by this? In the company, we must have this exchange among employees and employer. We have to strengthen the safety and health labor situations, but not only as to fulfill a requirement to comply with the regulation, but to promote the decision making and the participation of the workers. When you provide or you give the problem to the worker, he's able to propose some solutions. They get the risk and they become the main actors on the psychosocial risk to promote mental health. So workers must always be included and to incentivize participation. We have to recognize whoever is doing this work because it is not a simple work. And we must also have a social dialogue between employers and government. For example, this is a brand new topic, but we can have specific programs by type of industry. Standard 035 establish the tools to be used in the work, and they are designed to be used at any working center. But it will be more enriching if the industries develop these specific programs, because of course it's not the same risk factors that we have in the manufacturing or in the services industry, or for example in health services provision, or for example in the food industry. This collaboration and this dialogue between the government and the employer is quite valuable. It is not establishing a dialogue to find the best way to inspect the regulations compliance, but we will also have this intervention to determine labor illnesses, because when we have this uncertainty about how are we going to qualify this psychosocial labor illnesses, and not only that, but also how to collaborate with the government entities to approach the mental health services. We are in an interesting impasse where we are generating a better awareness, a better diffusion and sensibilization about the mental health. What we must also make more efficient and reducing the barriers to the mental health attention in Mexico. So bridging this gap in the intervention is something that will not be solved by the government, but not only the employers, but by working all together. Yes, I entirely agree. Something that finally it's very important is to recognize that we have to form more mental health professionals. And I'm also talking about labor mental health, because this is something specific where you have to master not only psychiatry, clinical psychology, health, but you must also have everything about the legal part, the corporation part. And it is very important that the health professionals on labor have this instruction to participate in mental health. And it is quite a requirement to do so. I entirely agree. I think that something that we talk about in this Congress are the gaps in service, in attention. It is a situation that we have seen in a lot of groups, in vulnerable groups, in the general population. And the working centers are not exception. I think that we have to generate strategies to break these gaps. Now I would like to introduce Dr. Nidikar Yamar Roman Ramos. I think he's already here. I'm going to read part of his curriculum. He's a surgeon from the Metropolitan University, specialty on labor medicine. He studied at the high specialty IMMS at the Siglo XXI hospital, and he's certified by the Labor Institute. He has participated in all these programs that the IMSS has developed, and currently he's the head of the surveillance area at the IMSS. I heard that he is already here.
It's great to see you. Thank you very much for being here. I understand that we had a few issues when with the earthquake, and there were some protocols to follow to get here. And that's good because protocols keep us safe, safety first. So, Dr. Nidgard, we were just talking with Dr. Marida. We were discussing on everything about the need for promotion and identification of the psychosocial work systems and some strategies to be implemented. But now that we have you here, I was wondering if you could tell us a little bit about the ELSA project and the line 4 of the ELSA project and how it addresses from this program everything when it comes to the psychosocial labor issues. Of course, sure thing. I'll be more than happy, Dr. Paredes. I would like to greet all of the audience. Sadly, we had to adjust to the situation and adapt to the protocols to address seismic alerts. And I am also part of the brigade of my area, so therefore we had to invest a little bit longer in addressing the situation. No, we would like to thank you for being here. It is my pleasure, and yes, first things first, I would like to greet you on behalf of Dr. Velasco, the head of the coordination. She is a key piece of the ELSA factor of the ELSA program that I will be talking about in a minute. Well, now talking about prevention, at least in the aspect that we manage it in the institute, I would like to mention first of all that in the services that we provide, there is a very important factor that's preventive area. What we're looking at is intervening before there is any sort of harm to the health so that cases do not complicate, or identifying the risk factors so that we can have a positive impact and we can generate changes in them so they don't see their health affected. And after the case-based scenario and information that we collect based on accidents, work, disease, and all the information that we collected along the years in the Institute, we have identified some factors that have a specific influence on the damages and harms to health. And that's why we have this strategy called ELSA, which is healthy work environments. This is a program that looks to foster well-being and safety. We're looking at the prevention of disease and accidents, and within this, we include the psychosocial risk factors that this line 4 specifically addresses. When we talk about lines, we essentially mean that based on the case-based scenario that we manage, those were identified as the main harm to health of the population. We identified accidents on hands and ankles and skeletal disease. And this is essentially the line that we covered and are related to psychosocial elements. What we're looking at, Francisco, in this part, it's we're looking at a promotion of a work environment that's good and beneficial in companies, all the companies that are subscribed to the Institute. We get to support them with tools that help them to comply with the regulation 035 as well as the modifications and updates. So what we look for is to provide elements that will help them identify, analyze, and prevent risk factors from this line 4 that we are talking about. In the line 4, we identify different risk factors that are included, such as the work environment, regulatory compliance, the conditions, work conditions, the workload, the days, shifts, the relationship with their family, poor leadership, and obviously labor violence. Why? Because based on the definition of different factors, some issues like anxiety, non-organic cycles of sleep, and constipation, and generalized stress are allocated to the nature of the role. And this is a very important factor to consider because when we when we identify them, all of these points become very relevant when we are carrying out recommendations or carrying out strategies within the company to tackle these risk factors that were identified. We need to consider the type of workload and days, either night shifts, if you have, how many shift rotation do you have, if they don't have recovery time in night shifts, or if they are exposed to traumatic events, and the exposure to work violence. I would like to invite everybody to look at the ELSA with double S, ELSSA, and to the website in the institute. You can upload, you can access this platform, and you can look at all the material that we have available in ELSA. And this is a material that we use, and it is in the how we have the line 4. Companies get to fill a checklist where they highlight what is the compliant points of this list that we are proposing, that we're providing. If they don't have or they can identify any points that are not complied with, or maybe they identify this with an improvement area, we can provide material, reference material that you can use as a basis, where we say step by step, how can you do any changes needed to improve these health conditions of the population. So if you go online, this is also part of my promotion to invite you to check the website out. This material that we have, it's easy to download, it's a PDF. You can also review the lists, you can take a look at it, and it is worded in such a way that's easy to interpret by the people that are in charge of the safety and security in the workplace. So through this tool, we're trying to become facilitators and enablers for the companies so that they can carry out any changes needed from the identification of the risk factor all the way to the actions that are meant to support and carry out the improvements. Something that we're always looking for, and I really want to use a short time that we have available. One of the strengths that we have with ELSA is that this is a three-party system where you would have the company collaborating alongside with the worker and the institute itself. As you might have realized throughout these conversations, in the participation of the staff, of the workers, bringing the leaders on board in the companies for them to identify these risk factors as essential for the healthcare. This is urgent because it is much easier to work all together to identify from the risk factors, how do we address them and how do we identify them. We're all engaged in improving the mental health of the workers. So all of that is stated there. We work on the psychosocial risk factors, identification and analysis of the risk factors, prevention of risk factors, work violence, the promotion or fostering of a healthy psychosocial environment, and an improving one. We talk about the negative factors of the psychosocial aspect, and we have this as a free resource. Now, the companies that are already in ELSA, not only do they do their self-evaluation with this checklist, they can also request advisory, either virtual or face-to-face. We have specialized doctors and engineers that could go to the workplace, or they can virtually attend the meeting to review this list, this checklist, do an external visit to prevent any tunnel vision. Now, with the staff that's specialist, that they will support the company, they will provide advisory, they tell them what are the opportunity areas that were identified, so that the company, once they identify this, they get to work on them. These advisory meetings are something that you can do yourselves from the material in the ELSA website. We actually invite the companies to use this sort of tools because, truth to be told, they're very useful when it comes to this. We also have trainings in the CLIMS platform, CLIMS, CLIMSS, where you can access. We have a training called Prevention of Work Risks Related to Psychosocial Elements. We are looking at this course to be made for the workers so that they can take it, they understand what this is about, and they get to also understand what are the risk factors and communicate this to the safety or security committees that they have in the companies. Tell them, okay, identify these risk factors. Why? So that the business people or the managers, once they acknowledge this, they can carry out the identification assessment and, of course, the controls involved in these kind of events. So what are the benefits that we're aiming for? I believe this is also key to what ELSA is. We look at a well-being and a better life for the workers. Let me mention that us as IMSS, we have a little over 22 million workers affiliated. If we have a positive impact in these 22 million workers, and especially if we think based on the reports, if we think that workers tend to have mental health issues over 15%, we could, through these processes, have a positive impact, a healthy impact in a little over 3 million workers that we can identify. So we're looking at the reduction of absenteeism, we're looking at improvement in productivity, reduction in presenteeism, in absenteeism, in any medical permits. We try to reduce the medical costs or the cost in general until with these sort of issues. We obviously look at an improvement in the work relationships. We try to create healthy work relationships. And we obviously look at the fostering of healthy habits. Just to wrap up on the side on what I wanted to mention of this program, I would like to mention some figures that we have had since our launch last year in May of to date. We have seen a little over 16,000 advisory meetings for Line 4. So we mean we have had a doctor and an expert going to the 16,000 work centers to do an advisory on this Line 4, which is the prevention of work diseases related to psychosocial factors. And these work centers, along with ELSA, we have identified that is specifically for the Line 4. We have had influence in over 2,400,000 workers with the line 4. So we believe that this is a strategy that's of course growing. It's fairly recent. It was just last year, and we're looking at promoting it, asking companies to use it. Of course, the material, if you use it, do download it, do use it. And this is what we're looking for. We want to create this promotion and culture so that people test out this program. That would be it, Dr. Paredes. That is amazing, Dr. Nidgar. There were several things that I find really interesting. The fact that this might lead to the decision makers in the companies, because I believe they're the ones in charge of looking at the benefits. And considering that all of these programs allow us to create an improvement, not only in the productivity side, but also in the health of their own workers. And well, since we don't have much time, I would like to thank the audience. We went a little over the time that we had scheduled, but we'll take a couple more minutes so we can wrap up with this conversation, because I think it's very important for us to be able to emphasize some of the things that were discussed, like the creation of a well-being culture. And just as a conclusion, I would like for all of you to talk a little bit about this. For instance, Dr. Merida, if you could help us work talking about any initiatives or specific programs that have proven to be effective to show how including the employees in a proper work environment makes it a healthier place. Francisco, luckily we already have experience. We have models that the organization itself, the World Labor Organization, has reproduced. We have the Solve program, for instance, that has behind it this matter, this social factor, the three-party participation, the guarantee of rights, the increase and the impact and productivity. So I think those are some of the models that I personally believe to be very valuable, because they comprise the physical and the mental health as a single unit. They tackle several aspects related to risk, elements like substance use, lack of physical activity, lack of proper sleep. And it talks about stress at work, and it essentially creates a network that I want to say makes it a solid model. I think we deserve an update. I believe the last one was in 2002, and I personally think that there should be efforts ongoing to update and reactivate this model. That it's very solid and it's a great resource. We already have a competency standard that is acknowledged, recognized, and assessed to implement this methodology from the World Labor Organization. And we have also seen success stories both in work centers in Mexico and in Latin America. Another way we can start working on this, so to speak, is getting close to the academic community. We have colleges and universities like the Morelos State University and the psychology school that has a very strong group of researchers that would immediately love to collaborate with the companies for the development of these programs. Or the Guadalajara University also has this nuclei of investigators and researchers that are willing to participate. So I believe it will be very useful to approach the academic community. We also know that from the international standard organization, we have specific competencies also talking about psychosocial matters. So another benefit of implementing ISOs is the international relevance and how useful it would be in the exchange of products and services between countries, where there is a requirement for the company that is providing this service or product to have these sort of certificates in the ISO standards. There is also quite a lot of experience inside of the companies, the larger companies with developed culture around mental health have many programs already that are indeed addressing the well-being and health of the workers. However, it is very important for those to be part of their managerial system, risk management systems. So if we do not have an integration or a system-based risk assessment tool, the time frame of these sort of programs is at risk. There is also some awards and acknowledgments from private institutions and public institutions, certifications, awards that might be a guidance where they can start working on these sort of efforts and a motivation for the organization to reach this sort of awards and acknowledgments. I believe those could be some of the initiatives that are at least are tested to have an impact in implementation and promotion of these sort of programs. That would be it for my side, Francisco. Thank you so much, Jorge. I believe these are initiatives that are indeed going to be easy to replicate, and we can do more research on it, which will give us the possibility of having a follow-up. Dr. Nidgard, would you like to mention anything else in this conversation that we have had? Is there any other comments or insights you want to share? Yes, of course. First things first, I'd like to thank you for the invitation. Being able to consider in such large congresses the public participation, it would be great for them to understand and integrate the influence of the labor on mental health. So this is quite a relevant subject, and I think the fact that it is already considered within the subject, the mental health as such, it makes it even more relevant because the stories where a lot of people are the largest amount of time that we spend in our day, it's in the work sector. So we have a positive influence in this environment. We can then set or create an environment of protection, not a damaging one. We go to work because we do things that we enjoy, we do processes that we were trained for, we receive an income. It keeps us young, we do effort, we grow. So the point is for this work center to be a protective area or a safe area for this. So this should be good for both the workers and the company and the business owner. And when we're doing an identification of risk factors, we have to consider all of the population. We are thinking about the damaging elements, and it's all coming from a healthy population or the population that's considered to be healthy. We need to start from this baseline for us to identify risk factors and we can have a positive influence on them. After this, we will then see a great improvement for our working population that I mentioned. It is a good part of the population, and this is how we can favor their or improve their lives. Thank you. Thank you very much, Dr. Nidgar and Omar, Dr. Jorge Merida Pu. Thank you very much for being with us in this conversation. Thank you twice as much due to these issues that we saw at the start of this conversation. And we would really like to thank you for your attention, especially the highlights on the need to address the mental health issues in work environments. We really want to thank you for your participation, and we will then continue with the program. Thank you very much, Jorge and Edgar. Thank you very much for your time. No, thank you. Thank you.
¿Ya cerramos? Agradecemos la
We would
participación.
like to thank you Dr. Francisco Paredes Cruz, for your participation in this dialogue on the prevention of psychosocial risks and the fostering of mental health in a workplace. It is very important for all of us that are in our working years. Dr. Joaquin, thank you. We would like to thank the audience for staying here with us in this wonderful and enriching second day of Congress, where the participation of our dear leaders across the different areas of mental health are guiding us to increase our knowledge on these regards. Likewise, we would like to thank all of our panelists to bring mental health to such an essential point that it should occupy by default, and for sharing their knowledge. We'll wait for you tomorrow so we can continue with our third day of activities. Thank you very much. See you tomorrow.